and lots of energy. So where is ZP? Is my selector ready with ZP? Yes, these are young people. The energy is also young. Call your crew. Come. Kuja. Good. DJ, if you are ready, ZP and Sam are ready, and everyone else is allowed to join the AYPs as they do their thing. Karibuni sana ZP. DJ. DJ. Okay, tukingoja DJ, we are again, as I said, ni AYP session. Si tumetoka kula lunch. Si the food should go down. Ama ijiland kwa stomach vizuri. So let us stand all of us kindly. Let us stand. Good. Let us hold our head as Ma. This is Ma. Mato. Matoyo. Matoyoyo. Ma. Mato. Matoyo. Matoyoyo. Good. So we can do. Sindio? So let's go. Ma. Matoyo. 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 Ma. Matoyo. Matoyoyo. Nani anabaki nyuma? Ma. Mato. Matoyo. Matoyoyo. Ma. Matoyoyo. 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 Ma. Mato. Matoyo. Matoyoyo. Ma. Mato. Matoyoyo. Matoyoyo. Last challenge. I need a winner. We need to give to someone. Ma. Mato. Matoyoyo. Matoyoyo. Ma. Mato. Matoyoyo. Matoyo. Matoyoyo. Matoyoyo. Mato. Very nice. Asanteni sana. We can grab our seats. Kindly, ladies and gentlemen, allow me to introduce, where is Rose? Rose will share with us an overview of why we are here. Karibu sana, Rose. The stage is yours.
Okay, good afternoon. My name is Rose Chepkirui, and that's my bio over the screen. So being an AYP focus session, our attention is fully on health, well-being, and lived realities of young people, and how integrated health services are responding to our needs. So this session on AYP Community Village will serve as a live demonstration platform, translating policy dialogues into practical youth-centered service delivery and engagement. So as we all know, adolescents and young people form a significant part of our population, yet they continue to face barriers. So number one barrier that we face as young people include limited access to youth-friendly services, stigma and discrimination in our health facilities, gaps in HIV prevention, testing, and treatment. So we are in the Integration Summit. How will the future look like for young people? And that's why we are having this session today to talk about real-life issues and brainstorm on how the future will look like. So to strengthen integration for young people, we must expand youth-friendly and confidential services, promote economic empowerment alongside health education, and ensure equitable access to SRH and HIV/TB services. So to transition to, or to I've given an overview. So we want to amplify our voices through holding different sessions in this afternoon. So we are going to start. I will introduce our two speakers. And our first speaker will share how they work in the community to empower and improve young people's well-being. And our second speaker will take us through condom education, a critical part of HIV and STI prevention. And I feel that this speaker really has a backbone, which she will share with us, how she started, what she realized was a gap in her community. Then to our second session, we are going to have we are going to hold a panel. And today's panel features young leaders who are also experts across key health thematic areas, including HIV, TB, maternal health, and malaria. So they will share an insight in strengthening integrated adolescent care to ensure young people access holistic and youth-friendly services. We shall later on conduct a debate, which is a session I'm looking forward to. And we hope that we shall all participate and support the topic. So without wasting more time, I would like to introduce our first speaker to give a live discussion to this session. So let me welcome Franklin Wanyama to stage. Where is Franklin? Oh, you're here. Okay. Come and continue.
A round of applause for Charles tafadhali. Makofi ya Frank tafadhali. Hatutaka kwa AYP hivyo. Hapa kwa AYP tutaka hivyo. Makofi mazuri kwa Frank. And you just need to reflect, when you are Frank's age,
the hospital.
Uliwahi attend any summit?
Yeah.
Uliwahi? Good. Makofi ya Frank tafadhali. Frank, kumbuka dakika ni zako 4 na zimeanza sasa.
Okay, kwa majina naitwa Franklin Wanyama ama ukipenda Mr. President. Kwa majina naitwa Franklin Wanyama ama ukipenda Mr. President. Najua mnanipenda sana kwa ile mambo ingine. Ile ya ground, ile ya kusalimiana, but sasa leo hatusalimiani. So I started from OTZ champion, whereby nilikuanga OTZ champion at Fikiria Jamii. That's where my journey started. And Fikiria Jamii had 14 facilities where I was empowering them on how to live positively with HIV. And in that journey, I went public on my status, that is, okay. So, before niendele, okay, acha nimalize hii ndio ndaonyesha slides. So, I started as an OTZ champion, that is from EDAP. I went public on my status, and through that being public, it was meant to reduce stigma and inspire openness. I formed a group called Hope Family Welfare WhatsApp group, whereby I brought people together, whereby they can share their ideas, they can share themselves. Through that, I formed a CBO called Smart Hope Organization. And through Smart Hope Organization, I formed another group called Hope Family Welfare, whereby members wanted to assist each other. And as we speak, we have already assisted with more than 1 million from different counties. And from Hope Family Welfare, because it's an umbrella, we started forming other groups in the county level, and we have managed to reach 38 counties. And from the county level, we have managed also to go up to the sub-county level, whereby they come together. I empower them on how to form the groups, on how to register, on how to work together to bond and empower themselves economically. The vision is to create a supportive and empowered community for young people living with HIV and young parents living positively. Why did I do this? I did this because most of us, when we were growing while we are HIV positive, we had a lot of questions on how we can be parents, on how we can get married, and also on how we can have families. Also, our mission is to promote adherence and health education, promote emotional, social, and welfare support, whereby when one of us has a problem, we come together, we mobilize resources from that WhatsApp group, we go and visit them, or we offer them support, like a NOTZ member who passed away in Madare. We assisted, we empowered the family, and also went for the burial. We also encourage public disclosure, whereby those who are willing, we can mentor them step by step. We have their WhatsApp group. Facilitate economic empowerment through group savings and investments. We have groups whereby I empower them on how to save. They elect their leaders, they save. I look for other financial advisors like cooperative, ICA, whereby they support them where necessary until they do the activities. Also, as I said, we have gone into 38 counties across Kenya, of which I am the president, while I empower them, and also they make their leaders and also empower more people. The counties that we are in are Mombasa. Mombasa, we have 2 groups, Kwale, Kilifi, Tana River, Lamu, Taita Taveta, Garissa, Isiolo, Meru, Tharaka Nithi, Embu, Kitui, Machakos, Makueni, Nyeri, Kirinyaga, Murang'a, Kiambu, West Pokot, Trans Nzoia, Uasin Gishu, Nandi, Laikipia, Nakuru, Narok, Kajiado, Kericho, Bomet, Kakamega, Vihiga, Bungoma, Busia, Siaya, Kisumu, Homa Bay, Migori, Kisii, and Nyamira. Okay, organization structure, we have a national level whereby I'm the president. I have my deputy, who is also called deputy president. We have a small cabinet. We have the county leaders of family movement, and also we have sub-county leaders. So it makes our work easier to reach that member at the sub-county level. Apart from these leaders, because we have over the national, the entire family movement has around 100 leaders countrywide. So we mentor them, they share their issues from the ground level, and we are able to assist where necessary. Under that, we also have sub-unit, whereby we have some staffs from several facilities who have come on board who want to assist. We have around 32. These are peer mentors, adherence counselors, people who can help us also in other issues in the WhatsApp group. We have public disclosure group, those who have gone public. Sometimes kama kuna something that you want to address, I just share there. Those who are public, you will see it rolling in the social media. Group activities, they meet after every 2 weeks, bond, discuss adherence, mental issues and welfare, financial and welfare. They do merry-go-round, table banking, money market, contribution, livestock production, ng'ombe movement, that is done by Bungoma, Mbuzi movement by Vihiga. Some groups have purchased lands, whereby I mentor them, I show them the process on how they can purchase their lands and have beneficial in future. This has helped in improved adherence, mental well-being, and also financial, collective savings, investment, and asset ownership. Under the social, it has reduced stigma, peer mentorship, stronger community bond. The challenges that we are having: 1, limited and insufficient funds affect the group activities or outreaches, whereby unapata sometimes we don't have money to do the activities. We have weak group capacity, limited economic empowerment, lack of partnership, and technical support. As you can see on the slide, I think you can see on the slides whereby one of the groups, we have bought a land just behind Migori, that is Smart Up Organization, and that one is Vihiga doing Mbuzi movement. They have managed to buy for around 12 members. That is Ng'ombe movement and a Bungoma group. Yes, ile ni security ya Hope Family, they have their own nini, they have their own reflectors, and we have Hope Family media team that is helping in terms of covering our activities. Thank you so much.
Makofi
and may God
tafadhali.
bless.
Makofi tafadhali kwa Frank. A round of applause tafadhali.
Thank you so much, Franklin. Oh.
Msijali. Check, check.
Okay.
We are good, we can proceed.
Yes, thank you so much, Franklin, for that insightful presentation. I want to welcome Nancy for a presentation on sexual education. Thank you.
Nancy, dakika zako ni 5 na zimeanza sasa.
Good afternoon, everyone. My name is Nancy Gakuru. I'm a young AYP health advocate. I'm a social worker. I'm a peer educator and a counselor. Today, I'm pleased to talk about my work in Dandora. Allow me to read, because when I talk, nitaongea sana. So, my work in Dandora and Korogocho slum is not just work, it is a response to the realities that young girls and women face each day. Violation of their rights and lack of economic empowerment is a cup of tea that they have to sip each and every day. I focused on addressing what we call the triple threat, the interconnected challenges of gender-based violence, HIV infections, and teenage or adolescent pregnancies. These issues are deeply linked and continue to affect vulnerable populations in my community, especially women and young girls, as well as young people. I conduct sensitization sessions where I educate community members on the different types of gender-based violence, its cause, and practical ways of preventing it. Through this, I have... Sorry for that.
They want also to be put in this program.
Sorry for that. I conduct sensitization sessions where I educate community members on the different types of GBV, its cause, and practical ways of preventing it. Through this, I have created a safe and non-judgmental space where both men and women, especially the young populations, they can come together and talk about their real issues on violence, relationship, consent, prevention, as well as respect. One of the key interventions is that I started was inspired by a challenge I observed in my community. Glass bottles were often being used as weapons against women and girls, whereby you could get a woman who has been raped, and when they tried to raise their voice, someone would use the glass bottles to harm them or insert them in their private parts, which was very devastating. So I decided to transform this narrative by introducing a glass recycling activity or an income empowerment for my community, where we convert these bottles into beautiful and useful items such as flower vases, bowls, whiskey or water glasses, and other beautiful household decorations. Through this initiative, I demonstrate that tools once used to harm can instead be used to empower. This not only helps in reducing violence, but also provide economic empowerment to my communities, especially for women and young people, contributing to dignity and self-reliance. As part of ending the triple threat, I integrated sexual reproductive health education into my community. I actively promote the use of prevention methods, such as the use of condoms, as an effective prevention tool against HIV, sexual transmitted diseases, and unintended pregnancies. Through my engagement as a peer educator at Bar Hostess Empowerment and Support Program, I distribute condoms and provide education on their correct use and consistent use. The dump site this activity is particularly important at the dump site because I came to realize that most of the young people, they lack knowledge of usage of condoms, and most of them rely on plastic bags, which cause high health risks, as well as it's not good kabisa kutumia kutumia plastic bags instead of condoms. By promoting condom use and safer prevention methods, I empower community members to make control of their health and protect themselves from harm. Through my work, I continue to link GBV prevention, HIV prevention, and reproductive health, addressing the triple threat in a holistic and community-driven way. I strongly believe that when communities are equipped with the right knowledge, tools, and opportunities, they can transform the negative realities in their environments and create a safe, healthier, and more empowered environment for all. Thank you. Now I want to show you. Thank you. Allow me to show you some of the work that I've been doing at the dump site. So that is me picking the glass bottles at the dump site. These are after I have cleaned them, but not all of them. Kuna moja chafu hapo. So this is after cutting them and transforming them to a flower vase, but I've not finished because I have to remove the stickers and decorate them. So that is a marble vase. It can also be used as a flower vase. On the right side is a bowl. You can use it for popcorns or for soup. This was an activity I was doing against ending GBV, and I had an opportunity to sell the purple one, to a person who was traveling to USA. Kazi yangu imepanda ndege jamini. On the right is a barber shop. They have decorated their barber shop with my work. So when you get into the barber shop, the first thing you see, it's my work. The Smart Money Woman. This one I used to empower the people economically, and that is part of the work. On the right is the whiskey or water glass. And that is me empowering or sensitizing the community on safer use of condoms. Thank you.
Makofi tafadhali. Until she sits, makofi too. Another big question. When you are a hedge, what were you doing? Sindio? Yes. Sinamna hiyo? So you can see young people can do great things. So ladies and gentlemen, we don't want to take much time. And at this juncture, we have a very talented young person. Na ukikuja kwa space ya AYPs tunasema wewe pia unakuwa? Sisi wote tunakuwa adole, si ndio? Sweet 10, sweet 12. Tukienda sana tuko 13 years. Si ndio? So ladies and gentlemen, my DJ, you are ready? If you are ready, Zipporah and the crew tafadhali. Mjes, the stage is yours. Zipporah and the crew. And remember, in the entire summit, we are the only people who are awarding people or participants to sit in our session. It's only the AYPs. So we have gifts for each and everyone who has attended this summit. Makofi yetu tafadhali. Sinamna hiyo? Si tuna integrate. So ladies and gentlemen, my DJ, if you are ready, Zipporah and the crew, you are ready, twende kazi.
Siaka ni kutoka siaka kutoka siaka kila mtu siaka 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 ukichoma gode
DJ hello kauko kwa room, simameni guys, simameni kauko kwa room. It's your time to feel as a Gen Z, sawa? It's your time, okay? Sawa? So we are doing this, tafuta neighbor. Simesema ngome naimba. Hata mimi niko na partner wangu hapa. Tafuteni neighbor pia, sawa? Tafuteni neighbor, tafuta neighbor. Nataka kuona watu wawili. 2 by 2. 2 by 2. Usishike mwanaume mwenzako wewe. 2 by 2 guys, 2 by 2. 2 by 2 mko sawa? DJ nipe kitu. You do as I do.
Siaka
Let's do
siaka ni kutoka siaka kutoka
Shika jirani.
siaka siaka upito magode.
Hello. DJ. Spend your energy, guys. I'm a move. One last time. You pick it from the first, okay? Ni sawa, guys? Ni sawa? Hello. We're doing for the last time. DJ, nipe kitu.
Siaka ni kutoka siaka kutoka siaka kila
Shika jirani.
siaka siaka upito magode.
Thank you, guys. Thank you. That's all our time.
Good afternoon, everyone. I promise me burn like 5 calories. So, msijali, it was worth it. So we will quickly dive into our next session. And we have a very interesting session. So we are going to have a short and sweet panel. And we ask you to please pay attention and listen so that we hear from the young people. One of the most important things we constantly say as young people is that we are experts, we are professionals, we are doctors, we are clinicians, we are programmers. We implement and design programs at community levels. All of us you see here actually part of organizations, and we lead a lot of work at the community level. And today we'll be talking about some of the work that we do, but also help us to think, why is our voice necessary when we're talking about integration? I'll quickly start off with Navros, our very own doctor. We call him our doctor. And to you, Navros, as an AYP who works closely with young people on the ground, you sit at the intersection of service delivery and community trust. In the context of donor transition and the USG reforms outlined in this summit, how have you experienced the shift in HIV program resources at community level? And what immediate actions must county governments, national governments take to prevent disruption of integrated services?
Thank you so much, Jerop. My name is Navros D'Souza. I wear many hats, but here I'm a young person, but also I'm a healthcare worker, and also I do programming at Y Plus Kenya. So when it comes to the shifts in terms of funding, I think last year a lot really happened. And last year, when that shift happened, the people that were really affected were young people. And during that period, I remember we did a survey, or rather we did some during that time, and young people were telling us, for us, we can't go to the hospital because, quote unquote, Trump amena na pesa. And then you'll ask them, have you heard about shortages in terms of ART, condoms and things like that? They said, tumesikia. So as much as we always say that young people are informed, but again, misinformation is also targeting them. When misinformation comes, it goes to the social media, and they're the first people to get it. So coming to your question, what can we do in terms of county governments and national governments? I feel like as much as we talk about integration, and I'll start from where the panel left, that funding. Can we find a way of doing this domestically? I was participating in a budget process for one of the counties here in Kenya, and the funds that were put for HIV programs were, it was 1% of the whole budget. And it was one of the counties that were doing well. So how can we ensure that we have domestic funding that supports HIV program? This one will support us in terms of sustainability and ensuring that when that donor leaves, our people don't suffer. Another thing is we have to ensure that as we integrate, we don't dilute what's working. We know that peer-led initiatives do work. We know that OTZ clubs work. We know that psychosocial support for young people work. As we integrate, we ensure that we don't lose these things at work. Let's do everything. Let's do the convenient bit, but let's not lose what works. Because for young people, stigma is an issue. For an older person, and I'm also in the research space, we are currently doing a research around transition. Even in this current model, the siloed model, we find that young people still get lost. Between 24 and 25, they get lost. Now, if we integrate this into the facilities or do integration, then probably we'll lose more. So let's retain what's working and also tweak it in the current context. One thing we have to agree is adolescents and young people are a special group. They need that peer educator. As much as we want to run around with it, but they need that. I think I'll speak about two last things. We have to institutionalize AYP-friendly services. That is very important. We want where we can discuss our issues. It's costly, yes, but we have to institutionalize this and because it's worked, we have to ensure that we put it here. Lastly is, how do we strengthen community systems? How do we strengthen youth-led organization? How do we strengthen these organizations that are youth-led? And we have conversation around social contracting. I had the PS say that Dr. Muller is interested in social contracting. How do we ensure that these youth-led organizations are able to be supported to ensure that this program and initiatives continue to go on? Thank you.
Okay, thank you, Navros. Our second question goes to Raula. Kenya's PMTCT coverage stands at 90.1%, yet mother-to-child transmission rates are rising. In your work decentralizing maternal health resources, what are the most critical integration failures between HIV, antenatal care, and postnatal services at the community level, and how do AYP-led models address what facility-based systems miss?
Oh. Hi, everyone. My name is Laura Thuo. Okay, first of all, when we were thinking about the institutional failures in terms of integration, we have to look at the client journey, first of all. We take a look at a woman or a girl who has just gotten pregnant. A lot of us don't find out our pregnancy status in the clinic. We probably have bought this, we bought a rapid test at a quick chemist, and we find out that you're pregnant at home. So what's the next thing? You need to go to the clinic, to an ANC clinic. You go to an ANC clinic, and one of the requirements is for you to get a HIV test. For an unfortunate reason, the HIV test comes out positive. From this ANC, you are sent to another facility where you're going to be getting your treatment, right? Now, you have two clinics you'll be attending. You'll be attending an ANC clinic, and now you'll also be attending a clinic for collecting your ARVs. When we move on to the next, you now also need to be preparing to prevent vertical transmission to your baby.
From our data system, we're able to see
That's
that
another
people are aging with HIV
factor
now.
that you need to
I think I should already say
consider.
that the ARVs are
Delivery is still not at, it's not at the health facility where you're taking your ARVs. It's at either where you're getting your ANC, maybe they have maternal services, or you have to now access a bigger, maybe public hospital for you to deliver. So already
Chronic
we
illness,
can
we do
identify
know that as
gaps
you
where we
age,
can find lost follow-up. We can lose you either in between your ANC and getting your HIV treatment, or you can lose someone where between getting their HIV treatment and delivery, because now after delivery, now there's postnatal care. So those are some of the integration failures I find and we can identify.
and some of the complications that come with aging.
Thank you so much, Laura, for that. And I think it's important that we really realize that teen mothers, adolescent girls and young women who are young mothers really get lost through those different phases of transition. And a lot of time it's because there is no support system or someone to actually link them, or someone to make sure they actually got to the ART clinic, or they actually were able to access antenatal care. So thank you so much for that. I will quickly jump over to Ian from Migori. Ian, in high burden counties like Migori, malaria and HIV co-infection amongst adolescent girls and young women create health risks. Yet services remain largely soiled. How are you driving integration of malaria prevention, including IPTP, for pregnant adolescents into HIV service delivery points led by young people in the community?
Unable to assess and find this
Hi everyone.
and provide care.
My name is
And
Ian
the second
Kimani.
talks about mobility.
So first of all,
to assess and find out what are the mobility issues that the person has, and they're able to now provide care. Also, even far where they need.
sorry for that. So first of all, what I can say, youth-led service delivery is something that is very impactful to the community and the AYP as a whole. So for integration to work, some practical approaches need to be made. So, like you find the youths are very people that have their own rule, or I can say their own words. So this thing cannot happen when the youths are not given space. So having a youth-friendly service point, or that in that facility, having a youth-friendly room where this youth is able to feel free to come and inquire for service or counseling is something that can be able to support the youth in our county. And then the second thing, integrating of the IPTP in HIV care is something that can help in identifying of the youth, especially into the HIV and the ANC pathway, to help ensuring of early identification of our youth in their life. Thank you.
Thank you, Ian. On to our next question. We'll go to Alex from Busia. TB HIV co-infection remains a critical challenge, particularly among adolescents and young adults who are often diagnosed late. In Busia, how are AYP-led organizations leading active TB case finding and treatment adherence support? And what barriers in the current decentralized health structure prevent young people from accessing integrated TB HIV services without stigma?
And one of the things that you can be able to make decisions.
Thank you so much for your question. I go by the name Alex Opemi Saka. I'm from Busia County. I'm a TB champion, and as well as I chair Youths of Hope Busia, which is an organization of young people living positively that is supported by Y Plus Kenya. Thank you so much for that question. Because I'm giving my inputs about TB, I'll ask you to respond to me by saying Mulika TB. Mulika TB. Thank you so much. So in Busia, as Youths of Hope, we are partnering with Y Plus Kenya, and we are trying to use trained peer navigators to help us in the contact tracing and sensitization, door-to-door sensitization, and in the hotspots, whereby we target border riders, fishing communities, and fishing communities, yes. Secondly, we also integrate TB symptom screening with our HIV test for out-school youths. We are also partnering with the CASCO and SCASCOs for youth activities in Busia to ensure coordinated activities and community initiatives. And we are so grateful that we are given the first priority in Busia and our voice is heard. I would say that for this to work, we need to identify and do away with the barriers that are affecting us as for now. The barriers that are affecting us are hindering us from achieving. It is that we have limited skills and adolescents responsive communication. We also have limited involvement of trained youth peer navigators. Then we have limited youth-friendly corners or safe spaces, both at the community and the facility level. Thank you so much.
Thank you, Alex. Next, we are going to Zipporah. Teenage pregnancy is both a driver and consequence of HIV vulnerability among adolescent girls. In Nairobi's urban information settlements, how are AYP-led organizations addressing the intersectional risk of sexual violence, poverty, limited contraceptive access, and HIV? And what integrated services delivery model have you found most effective in reaching girls before pregnancy occurs?
Good afternoon. My name is Zipporah Chen. For those who don't know me, I'm a woman with lived experience, and I'm a young mother and an advocate at 5+ Kenya. So, as I address the issue of teenage pregnancy, first I'll have to say that teenage pregnancy is not always a service delivery, because it is also caused by poverty, whereby, as a lived experience, I got my child when I was in Form 2. I had information, but it was not the right one. I didn't know about, because maybe our parents were telling us to, these words of, how will I say it? Unapewa kitu in parable, usicheze na vijana. Mi akili yangu ilikuwa, nikicheza na James, I know I won't get pregnant because it's always a game. I was not told that if you have unprotected sex. Another thing is, let's talk about peer pressure. I'm in a boarding school. I've come home. My friend anatoka shule anashukwa, mi nanyolewa kipara. I will go and ask her, what do you do for you to look smart? We as peer, these peer children, we don't, atunyimana, atukwangi wachoyo wa information, atanipatia. Because I want to be like her, I will go knowing that if I have Johnny, Johnny will cater for this. So if I come back to your question, I will say that we thank our organizations, like as I come for Y Plus Kenya, when I gave birth, they came to our facility and they found me there. Now they started taking care of me and seeing how they can return me back to school. And I went and I finished my Form 4, knowing that now I'm a mother, I'm a woman living with HIV, and my life has to move on. I don't have to look at what happened. So empowerment, I was given empowerment. When I went back to school, I had that mind of, I want to help my child. And through that, I have become a pillar of other women in Kibera, whereby we think of what to do in order for our life to move. So I will say, starting with our organizations has really helped us and has featured and nurtured us to be the person that we are today. And again, working with other women, like I know I'm positive. I'm going to tell the other woman, I want you to be like me. Take your medicine very well, give your baby the prophylaxis, and let's see how life will go, because we don't count for tomorrow. That's what I will say for.
The next question.
Thank you so much, everyone, for taking the time to listen to us. If we had time, we have like 6 more questions for everyone. But because we have to save time, we cannot dive deep into. And we ask you to please master these faces and follow them and ask them if you do AYP programming and you need to figure out how to support your AYPs, I am telling you the solutions are here. We will give them a round of applause. Goja, musiclap, wacha niwaonyeshe. Sawa? Sasa we want to give them flowers. Flowers are important, even for men. You should get flowers. Sawa? Kirudi home, seme mnataka flowers. Okay, so I want us to collect different flowers and put them together and give them to the young people. We start with carnations. I say carnations, you say carnations, guys. We are doing it together. Integration. Carnations, roses, lilies. Hizo zingine ni gani? Tusaidiane hizi vitu. Sunflower, see blackjack hapana. So we wrap them with a nice ribbon. Sisi AYP tunapenda marash. So spray marash kidogo inukie vizuri, and then we give them to our young people. Yes. Thank you so much, our young people. So now tunataka ku photo. Oh yeah, we need to take photos AYP. Na mweke kwa ofisi yenyu na Dr. Mulwa. Weke kwa ofisi yako.
Wanasema niko na madoba mingi kama wild boss na bado uko na kwela fine, uko na piga fine, kila kitu yako msopa fine, acha tu step kwa land mine, so shake that thing, wind that thing.
Please stand and join us. None of you are dance. Please stand.
Shake that thing, wind that thing, so shake that thing. Sharongosa zungusha kwela, back it up, napenda vile una clap it up, ni kama round of applause, na umedunga blouse, msanii ana blouse, unachanganyisha bro, kitingisha zinapingika.
Nice one.
Wewe ni pro, umebeba kuliko
Nice one.
ya pro, mina let you go.
Daktari, hii si ndio, hii unainama hivi kidogo, alafu unapiga.
So shake that thing, wind that thing, so shake that thing.
Nice one. A round of applause to them tafadhali. Makofi mazuri tafadhali. And now I believe all of us can witness we are doing a good job as programmers from the national level to the county level. Sama namna gani? Si tunafanya kazi nzuri? Haya, wacha wapige picha, evidence walikuwa hapa. And I wish also the first 2 panelists can join us. Frank, Rose, you can join the team. Tafadhali kuini evidence mlikuwa. Very nice. Good. Picha isikue na kelele. Picha isikue. Very good. Makofi yao tafadhali. Now, ladies and gentlemen, we are getting to the top of everything. And allow me to introduce one of my leaders. Yes, young leader. Duke, you can feel free to be on stage. Good. So if Duke is on stage, ladies and gentlemen, allow me to hand it over to Duke. Duke, you can take it over unless you need any assistance from us. Na ukumbuke pia muda unayoyoma, tuko Mombasani, ni ladies night, ni ladies day, tuna integrate all our services and it's a Wednesday.
Hamjambo. My oh my.
Duke.
Yes.
You know, kidogo tu.
Yeah, okay.
Daktari, we are also seeking guidance from your table and desk, there is another young person who is concerned. Na amesema this space was specifically made for young people to come and share and address some of their issues. Daktari ameniuliza swali ya kwanza ni what is my reflection on triple threat? Nikamwambia Q&A session haijafika, but the question is what is our reflection on triple threat that is really affecting young people. So daktari, I know we are left with 17 minutes for the next session to come on, to move to the next session, but we are kindly requesting, because we might have some burning questions to the policy makers, allow young people to extend with 10 minutes so that they can raise their issues and their issues to be addressed. Tunataka power. Daktari, unatupea power. Daktari ametupea power. Young people, you'll have your Q&A session. We are extending our session with 10 minutes. Karibu sana Duke.
Daktari ni mbwekse si mbwekse. Very nice. My name is Duke. I'm a youth advocate, a champion, a young person living with HIV in this republic. I'm a farmer by profession. Like ile ya pesa, si ile ya kuchafuka. And najua mnashangaa kwani AYP wa siku hizi wako na vitambi. Tunachungwa vizuri. So musijali, sio ugonjwa ni baraka. I want to take you very quickly to something interesting. A very burning conversation within our country, a conversation that will take us to the next action, call for action. This is a debate, and I will introduce a motion. And after I introduce this motion, you as an individual, tutakuwa na session ya dakika kama moja, you will take a side. Sawa sawa, si tumeagree? Na si lazima hata uhame na vitu yako, unaweza tu hama ukuja mahali ya proposers, ama uende mahali ya opposers. Tuko sawa? This motion is on does comprehensive sexual education in school reduce teenage pregnancy and STI more effectively than abstinence-only programs. I will come back again. Does comprehensive sexual education in school reduce teenage pregnancy and STI more effectively than abstinence-only programs in schools? So, my proposers will be on this side. And my opposers will be on this side. I'm having a team of debaters who are coming to join me on stage. So, DJ yapewe power.
DJ, as you play, DJ kidogo tu, as the music is played, feel free to take sides. Proposers on my left. The motion. And then opposers on this side. Aya, DJ, as they move, another clarification that CSCs wanna take on my will be sitting on my right, and then abstinence will be on my left. Abstinence, we are maintaining this side. Abstinence, pure abstinence, this side. Comprehensive sexual education, we are moving to the right. DJ twende kazi. Aya. Aya, good my selector. Asante sana my DJ. Aya, we are closing the door. We are closing the door. Last call. Abstinence. We are for abstinence. We are for abstinence. My leader, you are for abstinence. Okay. Confirming comprehensive sexual education. Welcome, Mawe. Okay. Duke?
Yes.
We've already taken our sides.
Tuko tayari.
Tuko
Tuko na
tayari.
power. Sisi wote tuko na power. Now on stage, before I introduce my speakers, I want to specially recognize my judges. And when I recognize my judges, sasa kumbuka, this is the floor of the house. The time is yours. The floor is yours, but the time is mine. Sawa sawa. My opposers mpo. My proposers. Hawa wako rada. Hawa watashindwa hawa kweli. Our judges in the house is Dr. Emma Momanyi from CHEP. Makofi ya Dr. Emma. Dr. Jacqueline Kisia Ramka. Dr. Jackson Hongu, Unit 8. Dr. Fred Otieno, Nyanza Reproductive Health. And now to the floor of my speakers, my proposers. I want you to tell me, why does comprehensive sexual education in school reduce teenage pregnancy and STI more effectively than abstinence? Each of you have 2 minutes. And we are starting with the proposers and giving it to the opposers. Take it away. You start by introducing yourself, 30 seconds, and you have 1 minute and a half to propose your point.
Can everybody see me? Poleni bana. Kama mnioni, there's no way I can help you at this point. So, my name is Josephine. I work in the sexual reproductive health and rights space, and I also work with Y+. For the next few minutes, you will hear, oh, we are promoting bad manners, eh? But I encourage you, hold your fort. For the people on that side, if you feel like umeguzwa, feel free to come to this side, amen? To start with, if you look at the data, according to UNFPA, 1 out of 6 girls between the ages of 15 to 19 are pregnant. What does that mean? Young people are having sex. The assumption that we are not sexual beings and we don't see stuff is wrong. And that is what my opposers will try to tell you. I want you to remember, when you're talking about comprehensive sexuality education, we are not saying young people, adolescents, go have sex. No. What we're saying is provide accurate, scientifically proven, culturally relevant information to adolescents and young people. Let them be the ones to make decisions for themselves. We often say adolescents have agency, young people have agency. Why are we taking that agency away from them by denying them information? Why? We are not saying abstinence is bad, it is good. Please come join us and let them be able to continue receiving the information that they need. So, Marianne, this is about time you just come to our side, because I know you don't believe in what you're about to say.
Josephine, you're really wrong. Because you said 1 out of 6. What are the 5 doing? Abstaining. Isn't it working? Isn't it working? A lot of time we usually say, usimix business na nini? Sindio? And then why do we want children to mix books and pleasure? If us as adults we are unable to do it. Why? Now, the second thing is, you know, if sex is the only thing that we want our children to understand, and we clearly know that when you're becoming an adult, that is when you can take alcohol. Why don't we teach children, go and take alcohol? You will just take it anyway. Now, do we also say, we know you will have sex, let's give you condoms anyway? No parents really want to understand their child having sex. Chemistry inakushinda hata kupata 0.5. And then you want a child to learn how to do the styles and all that. Now you'll have a discussion on telling us how giving information on comprehensive sexuality education is important. But when you go to the other side, you want to say defilement is a crime. Please stand on one side. Pick one side. Because if you're giving a child information and the law says below 18 years, having sex with a child below 18 years is a crime. So what exactly are we doing? Promoting criminals. We need to pick a side as Kenyans.
I'm Navros D'Souza. We are being told that 1 out of 6 is too small. We should assume that. But let me give you some data. 260,000 HYW pregnancies per year. I think Marianne thinks that is too small. We should assume it. You're being told that you are here to teach about styles. We are not, and I would ask them and ask us to read the motion. We're not asking to legalize sex for young people. We're just saying give them the right information. We're not saying we're teaching them sex. We're here to teach them the right information. And clock it. Yes, and ladies and gentlemen, I know people, the next speaker will come and tell you morality, culture, morality, culture, morality, and culture. Our Holy Bible says, my people perish because of lack. Exactly. They will tell you here that information, education, and if education was the problem, then it means that the countries with the best education then would have the high rates of HIV and STIs. Germany, Netherlands, they are well educated, but their rates are so low. So let's not be lied to. And let me say this, we cannot fight HIV, teenage pregnancy, STIs with assumptions.
10 seconds.
We have to fight it with, we can't fight it with assumptions, but data.
Thank you, Speaker. You can have your seats.
Mighty members, clock it. Clock it. Haya, sawa. Time ni yangu, guys. So, abstinence is the only method that is 100, hakuna 100% effective in preventing both pregnancy, STI, zote, kila kitu. Clock it. Haya. And in contexts like ours, we are in Kenya, guys, kwa ground. In contexts like ours, where access to youth-friendly services is inconsistent, privacy is limited, and stigma is real, we have to be realistic about the method that actually works. Abstinence is not about denying young people knowledge. Where hata sisi tuko na knowledge. It is about empowering them with confidence, the agency, the support to delay sex, until they are truly ready, physically, emotionally, and socially.
You can leave the desk.
At this point, Jerome has exactly stated what we are saying. You've spoken about agency, about confidence, which is what CSC is about.
Order in the house. Order in the house. I told you one thing, the floor is yours, the time is mine. Did you just forget that? Okay. Correct. Be calm. Welcome.
Good afternoon. I support strongly that comprehensive sexual education is better than abstinence, in that, you know, you say abstain, people assume people are abstaining, but why do you deny the person knowledge to know what are the skills, how to use the condoms, to test themselves, but you're allowing them, telling them abstain. Not all of them abstain. You know very well that behind the scenes, they engage in those activities, that you're not willing to sit down and listen to your kids telling you we are doing the sexual activities. They do it and you know it. So it's better you advise them. Because for sure, knowledge doesn't corrupt people. It protects them. If they have the knowledge, they will be protected. Clock it.
Mnajua mmesikia tu mara knowledge hapa. Sai jioni tukienda kukula pale mtamaliza vitumbua na mnajua hamfai kula vitumbua, si ndio? Hiyo ndio mtaanzia. Sasa usiku utaenda text wako umwambia kurudia na unajua mliachana, si ndio? So is knowledge helping you out ama iko help? It doesn't, si ndio? The next thing, tumeambiwa sijui mara evidence, mara sijui nani alisema nini. If medicines work leo, si ndio? But if work, but at sometimes they don't work, what will you call it? Utaitaje? Inconsistent. Si ndio? Venye Jeropa amesema, it's only abstaining that you are 100% safe. 0 Hata kama jana ulienda usiku ukafanya ngono, si ndio? Ukatumia condom. How sure are you you'll not get pregnant? How sure are you through the year utapigiwa mlango uambiwe kuna mtoto? But mimi mwenye sikufanya ngono jana niko sure sitapigiwa mlango.
You are giving your argument basing on how you hope it to be, but we're giving our argument on the reality that is happening. And I would say, kama jana, we were here and we were asked to do the abstinence club, but it was muliona jana. A good number of us clapped. What about a sexual activity that has pleasure in it? What about that has pleasure in it? Because when these people don't lack information, they will end up doing it. Abstinence is not impossible, but we are saying it is difficult for people to practice it consistently, especially for the young people. Relying on abstinence alone ignores the reality. CSE ensures young people prepare for real life situation. Abstinence alone is not enough. When a person without information is...
Time is up, Mr. Speaker. Leave the floor.
First of all, you do not abstain inconsistently or consistently. You either abstain or you don't abstain. I'm Emmanuel Barare, I represent Y+, and I'm here to say that human and comprehensive sexuality education versus abstinence. We need to understand what we are fighting and why we are fighting it. I want to quote a very influential person who spoke in this room, who told us earlier today that nothing good comes out of sex. Now that is upon your own particular illusion. Let me finish. So therefore,
30 seconds.
So therefore,
order, please, members. Order.
We want to ask for CSE, but it's like we're asking our young people to fight a fire inside a building already that is burning. So,
thank you. And the famous person that was quoted is a researcher. Yeah, Prof. Nwati is a researcher. And if she was in the room, she'd be very disappointed that we are basing our arguments on assumption, yet there is data that supports CSE. I want our opponents here to say, where is that data that supports abstinence? Yeah, we can't use science, and we are scientists, we're in health, good people. So when we are told that somebody said she's a researcher, so our data shows that countries that have adopted CSC have lower rates of teenage pregnancy, HIV. The other things are suckers and stories are jabba jamani.
Leave the floor, your time is up. Thank you.
Now, I want to quote a reality. South Africa is one of the countries that has adopted CSE. But what exactly is this data among South Africans? Every other day, teenage pregnancy is there. And even if you look at the videos in schools, you see girls and you wonder, is this something that we can really implement in our country? Is this something that even as parents, I am sure, I am seeing a lot of parents here. You are seeing your 11-year-old and you hear that your 11-year-old is having sex with someone. What is the situation that you want to put your children over? Even in marriages, we hear issues of, I got pregnant, I didn't know. So what exactly do we want to put our children into by giving information on CSE? There's nothing about knowledge. You as a woman, you are married. You are not even prepared of siring a child. How is a 16-year-old able to sire? No, we are not allowing that.
As a parent, kama mzazi, which one would you prefer? For you to talk to your child about issues around STIs, issues around pregnancy, or unataka ende TikTok tap jioni apate huko? Pick one, pick a side. I will finish by saying, when we're talking about CSE, we are talking about protection, empowerment, and informed choice. Nobody is saying Go ye as adolescents and have sex. That's not what CS is about. It's about choice, it's about empowerment, and it's about bodily autonomy. Lastly, I'll close with saying, we do not protect young people by keeping them uninformed. We protect them by equipping them.
Thank you. Hey, Member of Parliament, why are you misbehaving? Okay, my people, clock it. Sasa, not you guys. Sasa, munisikize vizuri, nyinyi mnyamaze. Information does not equal protection. Decisions do. Number 2, abstinence is the only method that does not fail. Number 3, you cannot negotiate for condom use every single day, but you can choose to wait. Number 4, the issue... Wait, keep quiet, guys.
Madam Speaker, you are violating the ground rules. And please, I will speak to my judges. Yes, just calm down. Just calm down. Just calm down. Just calm down. I'm on the floor of the House. I told you the floor is yours, but the time is mine. Our judges, we request you, if any of the proposers or the opposers tries to grab the microphone from another...
The only way to never crash a car is not to drive it. Sindio? And Manchester United cannot win Champions League juu wachezi. Sindio? Correct. So, zero risk is the safest option. Sindio?
Order. Honorable members, heckling is not allowed.
Okay.
So, there's members of one party that are heckling. Why are you heckling? Just calm down. Clap for your speaker and let the speaker finish.
Yes. Clock it. Nice. So venye tumesema, zero risk is the safest option. Sindio? 0%. It's only abstinence. Uko na percentage ya 0%. Zero.
So, abstinence alone is a message, but CSC is a solution because you know what to do with the information that you get. For your information. Anyway, what I can say, not everyone engages in sex because they want. Some people are raped because you are at home telling your kid to abstain. So they will not be comfortable to come and talk to you, oh, I was raped here and here, because they're afraid what will come out of my mother's mouth. So, clock it.
Emmanuel, take it away.
If you saw, I was almost staggered here. So nataka kuuliza, if you want, have you ever heard of a place where people are being taught how to drink safely? But we want to teach our children and our teenagers how to have sex safely. Sindio? It's about education. So I want to give you this particular argument. Tumeamua the only way to have a 0% chance of crashing is not driving that particular car. The reason most of us want to agree we are here is because some people are told not to eat a particular thing and things happened. Okay? So, ni hayo kwa sasa.
Mr. Speaker, because I'm the last one to speak, I would request for 2 more seconds. I would like to start by saying, we are not teaching people on how to have sex. We are teaching them what sex is and the consequences of it. Secondly, as an engineer, as a good engineer, for you to have a farmhouse, you need to have a firm foundation as well, so that when floods come, do not sweep your house. An engineer cannot tell you to buy kununua mlango kubwa ndio floods zikikuja ufunge mlango. What am I saying? The foundation that we're instilling to our young people is information. Information will help them anchor and make wise decisions that can make them succeed in matters sexual reproductive health and rights. Thank you so very much, Mr. Speaker.
No, Marianne, the session is officially closed. Now, our proposers, si wako na kiburi? Ni information. Sasa mko na power. Mumeweka mawe. Sasa tunataka tuchague mtu mmoja hapa. Obi, ashainua mkono, njoo. He's a young person. Obi, to join us and support the proposers. And also on the other end, he said tumechukua a young person. On the other end, I don't know, any person who wants to... kuja opposers. Yes, mnataka nani? Aya, madam, I would request upatie point yako kwa the VIP. Yes. From behind there, wanasema gender equality. Gender equality. Okay, then we can get order in the house. I'm the one who is making the rules. Justus, can you sit down? Marianne will be disqualified. You are heckling on the floor. Okay. For safety, you'll take 1 minute. So can we have a lady on this side? Another lady? Yes, ma'am, come. Anne. Okay. On the other end, can we have a lady? Okay. Are we now good on matters gender? Okay. Quickly, 1 minute. Support your proposers. The other 1 minute, support your opposers.
Okay. Good evening, everyone. Start by introducing myself. I'm Obi. I support my team with the motion. And actually, I'll start by defending my point by supporting my team by saying, right now we are dealing with the different generations. India, we are dealing with a very different generation that is empowered, that is very fast, that picks information everywhere, right? So if we don't sit down with them and give them the accurate information that is needed about all aspects of sex itself, they'll end up making the wrong decision and blaming ourselves, right? They'll end up blaming their parents for not telling them about condoms. They will end up blaming their parents for not telling them about early premature relationship or premature sex. So it's about having that education with them, talking with them and empowering them with that information from the start, effect and the importance of the results of it. So I support my team and every point they raised,
Thank you.
100%.
Thank you very much. Let's hear from the opposers. And proposers, you guys are heckling. Oifanye?
Mimi naye nitasema hiyo CSC nilifunzwa mtu wangu, nikapelekwa hadi shule. Time nilipata hivi mimba, tunaniambia hapa story ya condom. Hiyo condom sasa yeye nilelei mtoto. Ningejua abstain, singekuwa nizima shida zote, kila kitu. Hiyo CSC nilipea kiburi ya kuendea hiyo sex, nisikie iko na nini.
Order. And take it away. Order in the house. Hello? Order in the house. Can we have order, please? Members, you are heckling.
Chebet, kindly.
Anne, take it away.
Okay, allow me to say this. My name is Anne Okaro. I'm fully supporting this team. As a teacher who works with young children, after COVID, we saw the numbers of high teenage pregnancies. But after infusing and integrating sexual reproductive health in our education curriculum, we have had the new teenage pregnancies, early teenage pregnancies going down. Why? We have given comprehensive education on sexual reproductive health. And in school, abstinence, we don't talk about it. Use of condoms, we don't talk about it, but we are giving them education.
Your time is up.
Education.
Let's hear from the opposers. Order in the house. Order in the house. Please.
Okay.
You're saying, are you trying to question that my timekeeper is biased? Oh, judges have taken the side. But they are neutral. So members, calm down. we cannot question the morality or the discipline of a judge until we sit on a tribunal. Okay? The judge has the moral authority to take a decision as he or she wishes to, and protected by the law. Okay? If you have a complaint, tutawapatia namba, mutaandika kwa tribunal. Finish it up.
Okay. I have only 2 points. Point number 1. In this world, people die because they've not eaten. People die in road accidents. People die having sex. Nobody has ever died from abstaining. Nobody. Number 2, sex and children come with responsibility. Sex comes with responsibility because there are consequences. You can make a baby, you can get a disease, an infection. How can you take care of a baby when you're still under the guidance of your parents?
Yes, now it's time, let's hear from our judges. Our judges, I know you've gotten a microphone. Our judges have gotten a microphone and they will start from any order. Our judges, the floor is yours. Brenda, I advise highly you should not influence the decision of the judges. I'm informed by the sergeant at arms that we have 1 minute for each. They don't. It's over. Okay. No. Order. No. You will not respond. You will not respond. So we are giving our judges time to continue summarizing up their points, and our judges are not biased. We said a member on the floor or a supporter on the floor of the house who heckles will make their members to lose some marks. So whoever claimed 1 term or 2 term or long term or half term, those are terms that we do not use on the floor. Okay, as our judges continue to get their marks and points together, no, our members will remain in the floor. Lennox, you can join us and give us a summary of the day. We will still get the marks. As you can see, our judges are really working day and night. They are burning the midnight oil even during the day. So let us give them ample time kindly.
Asante. Opposers ni fire, si fire. Proposers ni fire, si fire. Ngumi ni mbili ama term ni moja. Mnapea judges 2 term ama 1 term? 2 term, 1 term. Dr. Kisia?
You are not allowed to discuss the behavior of a judge.
Very well. I'll be giving the summary of what has been discussed here. And I'm glad that the young people of this country have proved to us whatever they carry. So to start with, Integration Summit is a very interesting moment in time where Kenya is shifting from we are shifting our financing model for healthcare. We are moving into primary healthcare. However, ladies and gentlemen, men and women, it is important that you understand that this challenge is very risky for the young people. The model that we are going to adopt going forward will either mean we are losing a whole generation or we are building. Listening here from Sunday,
the goal is clear. We want to maintain and not lose the gains we have had for the last 20 years. That is something that I'd appreciate the system, the policymakers, and the stakeholders. It is clear we don't want to lose the gains we have had. However, this is going to be possible if and only if we have models that are going to have peer-led monitoring, where we'll have one-stop shop for all the AYP services and a financed protection. Nancy Gakuru was on this stage before, and Nancy Gakuru spoke about how the young people in the ghettos are using polythene bags as condoms. I want us to reflect on that. Imagine we're in this one country and people are using polythene bags as condoms. As to whether sex is a priority or not isn't a question. Whichever side you stand on, whether sex is a priority, because someone would argue and say that must you have sex? That's not a question. I'm not getting into the debate. But one thing I want us to look at is the risk that these people are having. Dr. Githinji Gitahi on the Monday in the afternoon mentioned about health financing. 15% of a chicken and 15% of an elephant. We are not even at 15% of the chicken, because with our economy, we are chickens. But imagine the burden this is going to have for our health system. So, ladies and gentlemen, as we move out of this room, I want us to go knowing, are the judges ready? I want us to go knowing that 1% of our budget in the counties is what is allocated for HIV and AIDS. Is that sufficient? Think about it. We have challenges of misinformation and funding. That is what largely has been spoken on this floor. Thank you so much. God bless you and do you good. Comrades, power! Comrades, power! Viva, comrades, viva! Thank you.
Thank you very much, Mr. Lennox, for that summary. Now we can welcome our judges. I think these judges are now compromised. I'm highly advised, now that you questioned the behavior of the judges, only one will deliver the results. Na msimpige na kiti kama Chebukati. Tafadhali. So the judge, you are safe and you are protected. Welcome. Tupigie judge makofi.
To ensure all of us are walking this journey together.
Saseni, si mmefanya poa? Hapana? Oh, okay. So one, I want to
That is the bridge.
I want to thank both sides. You all did very well. It is a very difficult topic because that's my bread and butter. Teen pregnancy, gender-based violence, anything to do with adolescents. That's what I do in the Ministry of Health. And you had your points, very strong points, very convincing, but at the end of the day, we need to reduce teen pregnancy and we need to delay sexual debut. So, in terms of quality and relevance of argument, you did very well. Both of you. But for comprehensive sexual education overall, with teamwork, with evidence-based. Mbona mnanizimia mic? Ala? Na msinipige? So with teamwork, with evidence-based, let me start with abstinence.
Abstinence, you got 139 points over 300. That is 46%. Can we clap? For comprehensive sexual education, you scored 207. That is over 300. That is 69%.
The emperor, the conqueror, the champion, the lion is here.
Are we going to do this? Are we still going to do this? We have borrowed their style for all of them. Yes. So, at the end of the day, you can't translate knowledge or empowerment as a way of persuading or encouraging adolescents to have sex. When you are empowered, you can make decisions because you have the knowledge. Informative decisions. That's what we want, because every day when I'm dealing with Ministry of Education, they don't want comprehensive sexual education. Religious leaders is the same thing. But at the end of the day, if I know I will have sex and I will get pregnant or I will get STI, I will make informed decisions. Utakuwa uko na power. Thank you and may God bless you all.
Makofi yao tafadhali.
So I'm being asked who won. It is comprehensive sexual education, and this is the way we are going forward. Thank you.
So, to the winners high, to the winners power, ni noma si noma. As your moderator, I want to thank you, but not also thank you, because you heckled. The proposers really misbehaved despite them winning. This party, I think they poured money. I think there was use of money. And now I want to say thank you and may God bless you. Na asanteni sana kwa kushiriki nasi na Mungu awabariki. Na sasa mkipatana hawa vijana, please engage them. Please talk to them. We are so knowledgeable. We are experts. We are no longer participants, but influencers. Thank you.
Makofi yao tafadhali. Ngoja kidogo. DJ. Aya, we are taking a group photo. Our judges can join us. Chebukati, Cherera, 0.1, you can join. Cherera, you can join, 0.1. Dr. Mulwa, you can join them. Na nilikuwa nimewawarn. So we are doing a group photo. Yeah, you can join them. Returning officer mwenye alikuja na wacha nisiseme. Very nice. Brenda, you can join them. Very good. A group photo. Good. Judges tulishasema ni one term. Good. Thank you Mbwekse. So ladies and gentlemen, DJ, kidogo tu because of time, kidogo tu. So ladies and gentlemen, Dr. Mulwa had allowed us to extend with 10 minutes for a Q&A session for any question related to whatever you've seen here today. Any question, anyone with any question? Okay, 1, 2. Hey. Okay, we only have 2 questions. So we have, I'm being told we only need to, so how many questions do we have? One. I need someone to help me with the mic, kindly. I was working with Brenda. So I think he will go first. And then remember, before you pose your question, kindly highlight, are you posing it to the AYP or the policy makers? So you'll go first. Who else? Let me do to this side and to this side. Sinikuwe tu fair hivyo. So he'll go first, you'll go, you will go, and tena sasa. Okay, aya, tuanze. Your question kindly.
Thank you, MC. So I go by the names John Moy. In the morning, the PS mentioned, yeah? It's okay, it's okay. So as I was just saying, in the morning, the PS highlighted issues on mental health. And as young people, mental health is really a menace to us. Now, for the young people, sindo tunatumika kama spanner boy on issues of mental health, GBV. I want to give a statistic. I'm from Nyeri County, the land of milk and honey. And in Nyeri County, in last year, 2025, we had 906 cases of GBV. Unfortunately, 432 cases were SGBV. And so, secondly, now we can't ignore mental health, because mental health, personally, I view it as a driver and consequences of adherence to HIV treatment and NCDs. What do we call it? NCDs. I know you understand, right? So ignoring mental health is like the whole is like weakening. Mental health is really weakening the health system. And so my question is, I don't know who it will suit.
So we have two sides. We have AYPs who've done presentation and we have policy makers here. So your question, who are you forwarding to?
To whom it suits best. And so my question is, do we really think there is campaigns, adequate campaigns to the young people on issues of mental health, lifestyle diseases, and HIV prevention? Thank you.
I know someone has decoded that question. Where is the mic? And we are giving you 30 seconds kindly.
Yes.
Short and sweet. Short and sweet.
Yeah. Thank you so much. I'm so happy with the AYPs. And my question actually goes to those leadership within the AYPs. And this is my question. I'm thinking of intellectual disability, young girls who undergo rape and sometimes violence wherever they are. I want to know if any one of the group has experienced such a case and how they have dealt with it, because that is something that is common within our communities. Thank you so much.
Asante sana, najua pia mtu ameidecode.
Okay, thank you.
Okay.
Thank you so much, everyone. My name is Dr. Griffin Somondi. I work at Mohammed Methodist Hospital as the medical superintendent. I also have the pleasure of shaping policies at a smaller scale. My question goes to the policy makers in regards to comprehensive sexual education. So, is there a way in which we can actually design a program to make religious leaders who actually get 96% of Kenyans to understand comprehensive sexual education? I believe it is possible and we can work it out. But the question is, what can be the best way to approach them? with all these CSEs, if we don't tackle religious leaders into understanding comprehensive sexual education, we will just be beating around the bush because we teach them in school, but everything taken by evidence is less taken in than things that are taken by faith, particularly if they involve religious leaders. My question is, can we design a program for them? I believe it is possible and we can be part of it. Thank you.
Asante sana. Aya.
Good evening, everyone. My name is Travangao from Y Plus Kenya. We really appreciate the injectable prep that has come in. So far, tunajua, as this prevention method comes in, there will be rise of new infection of the STIs because the young people, hapa nao watu watatafunana, si uongo. So my question is to the policy makers, tukiangalia the AYP package, you may look into HIV, SRHR, mental health. So STI is missing. Can we advocate for it to be added to onto the AYP package? Kindly.
Asante sana. We are closing at that. So for the policy maker, I'm seeing Dr. Newton here. Dr. Newton is here. So Dr. Newton will take that question of how do we engage religious leaders moving forward? Because again, young people, we fully depend on our religious leaders. Yes, so Dr. Newton will do that. And the other question...
I'm answering one.
Yes. Let Dr. Newton first respond to those questions.
There are 4 questions, yeah, and we'll allocate them. I'll answer none of them. Yeah. So, Dr. Kisia.
Thank you, Dr. Newton. I will go for the sexual reproductive health and religious leaders. We have been engaging the religious leaders and those who go to church, and there is a program called ROPS. Have you heard of something called ROPS? And there are different programs in different churches, plus even in the Muslim, in the madras, I would say. We have engaged the AYPs and we have developed a peer-to-peer manual, which has mental health, it has STIs, non-communicable diseases, plus reproductive health issues. And at the moment, we will roll down our first TOT trainings, which will involve 50% of those who are going to be trained are AYPs. In Rift Valley, that is putting together 8 counties. So we are in talks with the religious leaders together with the Ministry of Education, because we know that target population is either in school or in colleges or in churches or in mosques. So we are on it. We have not been left behind. For the mental health, we have even developed a manual which is used for pregnant girls who are going through postpartum depression and psychosis or anxiety, depression. There is a booklet. And if you are here during the COGS conference, it was launched by the DG. So if you have any contact in the national, you can get a copy. I think those were the 2 questions which I wanted to answer.
Thank you very much, Dr. Kisia. I think you've answered 2 out of the 4 questions. I'll ask Liz to talk about the AYP package, and then you'll talk about the STI. policymaker.
Yeah, thank you so much. And I think Dr. Kisia has been able to address quite a number of issues that are affecting adolescent and young people. And I must say that we have been a step ahead as adolescent health from UNASCOP, from NSDCC, as well as from RAMCA, and non-communicable diseases, because together we have been able to develop peer educators guidelines. And I think they will be through the process of dissemination soon. Thank you.
Okay, thank you. The timekeeper tells me that we have run out of time, and we can, who is the moderator today?
Yeah.
Okay, go ahead.
All right. Good afternoon. Good afternoon. We are just finishing a very nicely heated discussion. I've also learned something today. And I think my take-home message is that still within the public health space, that we have a lot of interventions and we are at liberty to choose what works best for us. And we are hoping that the Ministry of Health can support the necessary steps so that we have information out for the young people. So thank you very much. I think that was very nice. Could we stand up and maybe shake it off as we prepare to go into the health products and technology session? Let's just stand up and shake it off. If you're happy and you know it, clap your hands. If you're happy and you know it, clap your hands. Hapo ndio inaishia. Voice yangu haiwezi endelea kupita hapo. Oh, ya Gen Z ni gani, daktari? Gani? Oh, DJ. Okay.
Party after party. Party after party. Party after party. After party after party. Nyama nyama nyama. Nyama nyama nyama. Ya pum pum. Ya slay queen. Leo niko fly car tingo ingo. Buruka tingo ingo. Wika tu biska tingo ingo. Buruka tingo ingo.
Chokora mapipa unakiuna Shakira pigo kuni dakira kamote mashira kokinya nadira unapokonda fira.
Thank you very much. Thank you very much. I have 2 left feet, so I couldn't do that. But thank you all who are here for this session. I know from the community villages, we have been discussing different agenda items. We have talked about NCDs. We have talked about issues surrounding the young people. We are looking at maternal child health. I was glad to see that the young people are already doing a lot around malaria, a lot around SGBV. And all these services can only be delivered when we have health products and technologies available to the different populations that require them. So I will not talk much. We already had on time. We will move on and start the next session. Allow me to introduce our first speaker, Dr. Nazila. Dr. Nazila is the head of department for the national, the head of the Department for Health Products and Technologies. She holds a bachelor's degree in pharmacy and a master's degree in health supply chain management, as well as a master's in business administration. She's a leader and accomplished strategist. She has coordinated many programs at the Ministry of Health, and she's going to take us through the expert presentation today. Please join me in welcoming Dr. Nazila.
Good afternoon, everyone. I see the room is like only 1/8 full. But I think we shall just continue because of time. So I'll be giving a short presentation on building resilient health systems, health supply chain systems in Kenya, what the Directorate of Health Products and Technologies is doing currently in terms of policy. As you're aware, the Directorate's main mandate is policy, and technical assistance. So, next slide, please. Oh, sorry. I didn't get SOPs for this. Yeah. So we are speaking of, and we're always talking about supply chain resilience. So the question is, what is supply chain resilience? I know most of us always mention it as the ability of the supply chain to bounce back, right? But more importantly, it's for the supply chain to be able to withstand and recover from those unexpected disruptions while still maintaining its essential functions. These disruptions can be due to natural disasters, for example, earthquakes, or a very significant event that took place a couple of years back, the COVID-19. We are all, that's very fresh in our memories. And right now, the geopolitical situation that is really affecting us and will soon be filling the supply chain pinches for essential commodities. Resilient supply chains is about anticipating, preparing for, and adapting to potential risks. And it's basically a proactive risk management, which is going to reduce the operational impact and ensure the business continuity, which is very important in health and especially in pharmaceuticals. Disruptions at any point in the supply chain can cause a cascading effect, such as delays in service delivery, increased costs, and interrupted service delivery, as I had mentioned earlier. So moving on, we're going to speak about the challenge that we have, and this is just a few statistics that I've picked up from Africa. We see that despite being home to 20% of the global population, Africa manufactures only a very small share of its demand of health products and technologies. These health products and technologies encompass pharmaceuticals, non-pharmaceuticals, diagnosis, assistive devices, which are very important, especially right now, and the fact that the government is really trying to ensure that we promote local manufacturing. So 20% of the population resides in Africa, but only 3% of our global pharmaceutical manufacturing occurs in Africa, with 0.1% of that being vaccines. So we are importing more than 98% of our vaccines, and we are importing 70% of our pharmaceuticals, which are sourced from imports. The African Union's 2063 targets is that the AU should meet its vaccine demand by 2040 by 60%. Remember, currently we are at 0.1, and by 2040 we need to be at 60%. I think we can all visualize where we are on that timeline and what we need to do. I will now move to the Kenyan context. In Kenya as well, we do import 70% of our medicines. Currently, we have around 30 pharmaceutical manufacturing companies, and we are hoping that we should be increasing this. We are also having funding challenges, and I think this has been a conversation during this summit about declining donor funding and what the country is going to do about it. We also had the issue of the KEMSA fill rate gap, but I know KEMSA is also having some reforms and the order fill rate have significantly improved. We also have challenges of drug expiry losses because normally we do not really monitor the way drugs are redistributed, the quantification challenges, FNQ challenges, delayed procurement, which all actually lead to our commodities challenges in general. So what's Kenya's strategic vision to ensure that we are on top of the game? We have 6 pillars of supply chain, and the most important one right now is local manufacturing. His Excellency, the President, is actually a champion for the local manufacturing in Africa, and therefore this is our opportunity to take this a step further. The local manufacturing that we are speaking of in Kenya, we want to improve and increase our local manufacturing, not only of pharmaceuticals, but non-farms and assistive devices, and even traditional medicines. We also have, Kenya is also highly invested in the Kenya Biovax Institute, and we hope that by next year, 2027, we shall have our first batch of vaccines locally manufactured. The second one is regulatory excellence. PPB is seeking to attain maturity level 3, and hopefully by March, end of the month, or early next month, we shall be in that and in that process. So that is one of the things that we are really working on, because the production from the Kenya Biovax Institute is also relying on Kenya attaining maturity level 3. Then we have the digital transformation. It is one of the bottom-up economic transformation agenda, digitization. Everyone has heard of the digital superhighway. So this is what we are trying to really incorporate in supply chain as well, where we are digitizing in conjunction with the Digital Health Authority to implement a comprehensive unified information system to achieve UHC facility dispensing system and track and trace, so that we are able to track a medicine from the manufacturer all the way to the consumer, that is the patient. Then number 4, we are also doing reforms in KEMSA. There is a KEMSA 2025-2030 strategy where we want to see that the order fill rate is greater than 90%. I know they are currently above 90, but we want them to get to about 98%. Then the other one is regional market shaping. One of the challenges that we are facing is that some of our manufacturers actually have highlighted that 50%, they are only using 50% of their capacity as manufacturers, and therefore we really need to look for them a market. And that market can only be done through regional market shaping, where we can aggregate all the quantities and be able to assist our manufacturers actually leap to at least use 80% of their capacity. At the same time, pooled procurement has its benefits, economies of scale, gives us cheaper commodities at a much discounted price. And finally, we are also looking at R&D and innovation, where we have KEMRI and BioVax, which is driving the vaccine sovereignty, and also other initiatives such as use of drones for delivery of commodities. So in local manufacturing, I just mentioned the Kenya Biovax Institute. It was established in 2021. The first vaccines, which will be typhoid and pneumonia, targeted for 2027, and the target will be 50 million doses a year. There is some funding from World Bank and partnerships with Biopharma for Indonesia for tech transfer and fill and finish. The other issue that I highlighted was the Presidential AU Championship, and this is an opportunity for us to amplify Kenya's voice in shaping Africa's and Kenya's pharmaceutical industry, policy, and driving continental investment. Currently, we have over 40+ licensed manufacturers who are supplying 25% of domestic consumption, but also the region, especially the COMESA. Then we have tech transfer roadmap, WHO, mRNA, medicine patent pool, MPP, has already been signed with Kenya Biovax earlier this year. And GMP trainings have already been conducted by PPB and PATH. We also have Korean Exim Bank pledging 32 billion for industrial development. In terms of regulatory systems, as I'd mentioned earlier, Pharmacy and Poisons Board is really targeting to achieve WHO's ML3. So they are already having those processes ongoing, GMP compliance drive, enforcement and market cleanup by ensuring that substandard and counterfeit medicines are removed from the shelves, and nationwide crackdown on unlicensed pharmacies. The track and trace system is also ongoing to monitor medicines from source to the last mile. And then investments and regional role. We are, once PPB acquires ML3, it will be hopefully the 10th country in Africa. And it's going to be positioned as East Africa's regulatory agency, providing regulatory reliance pathways to at least 14 countries. It is also the founding contributor to the AMA, that is the African Medicines Agency. Under that, we have, I'm sure people are asking, so what's the benefit of ML3? Because everywhere you keep hearing about ML3. So ML3 is basically showing or showcasing that our robust regulatory systems are critical to ensure quality, efficacy, and safety of HPTs. PPB is progressing towards achieving the ML3, which reflects a very stable and functioning regulatory system. Once we achieve this milestone, we will build confidence in locally manufactured products, promote regional pharmaceutical trade, and position Kenya as a regional hub for health products and technologies manufacturing and regulation. Kenya is also advancing regional regulatory harmonization through the African Medicines Agency to streamline approvals and accelerate access to safe, quality medical products across Africa. And this is actually one of the challenges that our local manufacturers and distributors are facing, that there's long lead times to get registered product within the region. And therefore, once the African Medicine Agency takes up, then it will be easier to have one regulatory authority registering for the region. Next is digital transformation. Here we're talking about the integrated logistics management information system. And we're hoping that we shall also be having AI forecasting, forecasting and quantification, and KHIS integration. So the Digital Health Authority is setting up facility-based LMIS that integrates data from various sources, including the PPB. So that is the digital superhighway. It's going to help us improve forecasting accuracy, analyze historical consumption, seasonal disease patterns, and procurement cycle for a 12-month forward planning. It's also going to give us commodity early warning. Real-time alerts will notify pharmacists and county managers when stock falls below the threshold, enabling proactive redistribution before stockouts occur at facility level. Track and trace of commodities and movement and utilization through the global standards 1 identification. And then finally, systems integration. We're integrating the system to enhance analytics and communication, including PPB registration systems, KEMSA LMIS in the facilities based on the LMISs. This will also help us to have accountability of our commodities and a one-stop shop to get all the data that we need. And I know the HIV program has been in this space for quite a while, and the DHA is actually learning a few lessons from that. KEMSA distribution reforms from survival to sustainability. The KEMSA 2025-2030 strategic plan speaks of full ERP digitization integrated with Digital Health Authority and SHA for real-time demand data. We also need to do nationwide stock taking to align physical inventory with warehouse management systems. Hub and spoke distribution. We target 7-day order to delivery cycle down from the 21 days, which is there. And county debt clearance drive. Counties owe KEMSA quite a huge chunk of outstanding balances, which limits the liquidity and supply capacity of KEMSA, and therefore there is work around that to ensure that KEMSA is always on top of things. And then the drug expiry tracking system, which is also very important. And one more, which is not here, but I know that the teams are working on it, is the drug donation system. We have a lot of donations which come in, and it would be really great to have these donations also being tracked so that we can be able to account for them. Strengthening last mile and community supply chains is also one of the areas that we are working on. Currently, we have 107,000 CHPs who have been deployed, and the kits, the CHPs have been deployed with the kits within the 47 counties. The ECHIS system is also up and running, and we want to ensure that they are integrated into the digital superhighway. So the fragmented data systems across ECHIS, KHIS, and ILMIS with no integration, which prevents national visibility of community-level stockouts, and therefore work is ongoing to ensure that all that is under one roof and integrated. County financing gap, the PHC is devolved, but most counties lack protected budget lines for community-level commodities. And we really do hope that the counties would actually utilize their FIF to be able to bridge that gap. Then transport and connectivity, we see that the northern and ASAL counties face unique challenges, nomadic communities, poor roads, network dead zones, and targeted solutions include stock tool being piloted. And then another innovation in this would be use of drones, where urgent specific commodities can be distributed to the last mile. Pillar 5, which is regional market shaping, that is pooled procurement and EAC leadership. So here, Africa CDC, pooled procurement mechanism. There's a continental procurement across the 55 AU member states, which is going to enhance reduction of unit prices for up to 35% on priority commodities. And Kenya is positioned as an anchor country and technical lead for the East African cluster. Further, we have the EAC pooled procurement system as well, the East African Community Bloc, which leverages on Kenya's manufacturing and regulatory capacity. Priorities for the EAC pooled procurements are ARVs, vaccine, malaria commodities, and Kenya's 30% EAC tariff preference provides for a cost advantage for the regional suppliers. Market demand aggregation, guaranteed volumes, a commitment to African manufacturers, low investment risk, and unlock scale of economies. Kenya's KEMSA order volume serve as a demand signal for BioVax production planning, along with the National Vaccine and Immunization Program. We also have the African Medicines Agency, where Kenya is a founding contributor. AMA harmonizes the market authorization across the 55 countries, reducing duplication costs for Kenyan manufacturers and enabling the faster registration of quality-assured local products within the region. We also have South-to-South collaboration, where Kenya's partnership with Biofarm from Indonesia for tech transfer, and also with South Africa. Then there is a 60 billion market opportunity. By 2030, African pharmaceutical market is projected to grow to 60 billion. Currently, 70% is supplied by imports, so Kenya aims to capture the EAC manufacturing share, creating export revenue, forex earnings, and industrial employment. Finally, we have research, innovation, and KEMRI, which is Africa's scientific backbone. There's 150 active clinical trials per year. KEMRI Wellcome Trust partnership generates evidence informing WHO guidelines and African regulatory decisions. Kenya is a global site for HIV, malaria, TB, and emerging pathogen research. And what we want to do here is we want to translate research into commercialization. So that's where the focus is. We're also doing disease surveillance, sentinel surveillance for HIV, TB, malaria, AMR, and emerging pathogens, provide critical demand intelligence for supply chain forecasting and strategic stockpiling positioning across Kenya's 47 counties. Tech transfer, I think I've mentioned this earlier, where KEMRI supports BioVax in the mRNA and adjuvant formulations and links to University of Nairobi, JKUAT, International Vaccine Institute, Partnership for Typhoid and Pneumococcal Vaccines, targeting the 2027 production. And then finally, capacity building, 500 African scientists trained per year through KEMRI fellowships and exchange programs, building the continental scientific workforce essential for sustainable innovation, bioequivalence testing, and quality control. So what's our call to action and commitments that we need to make in this summit is one, accelerate domestic financing. We need to ensure that GOK to increase domestic financing for all strategic commodities, but also for non-strategic commodities such as the NCDs, from the current 20% to 40% within the next 3 years. We also need to close the KEMSA order fill rate gap. Currently, it's at 92%.
She also serves on the steering committee of the Coalition for Access to NCD Medicines, and her many other accolades are on the projected as shown. Thank you, Daktari. Let's appreciate Daktari. Our second panelist is Dr. Immaculate Kathure, OGW. Yeah, for those who don't know OGW, we can see her later. It's a very prestigious accolade that you get from the presidential awards. Daktari is heading the Division of Tuberculosis and Lung Diseases. She's a medical doctor with specialization in public health for over 18 years experience, and she coordinates TB control activities in the country. Let's appreciate Daktari. The other panelist is Dr. Wako Ejesa, OGW. Yes. As I had mentioned, that this panel is really privileged. So Dr. Wako is a seasoned public health physician and a health system leader, the current Chief Executive Officer, Kenya Medical Supplies Authority, commonly known as KEMSA, and he is charged with providing overall strategic leadership and management of Kenya's National Medical Supply Chain Agency. He's rose up through the ranks from his days as a medical intern. He led the district, the province as a provincial director, and then he's led 3 national programs, TB, malaria, NCD, as he proceeded on to lead the largest, or the National Medical Supply Chain Agency, KEMSA. Thank you, Daktari. Let's appreciate Daktari. My other panelist is Dr. Evan Simbuki. Dr. Evan Simbuki is the program manager of the health products, HIV health products and pharmacovigilance at NASCOP. He's a health supply and program management pharmacovigilance specialist with over 21 years of experience. He coordinates all activities related to HIV health products and pharmacovigilance at the national level. Up is his bio. Thank you, Daktari. Let's appreciate Daktari. I have the largest panel. So because commodities are important and commodities cut across several health products cut across several products. We have laboratory products, we have pharmaceuticals, we have non-pharmaceuticals. So on stage we'll also have our colleague from the National Reference Lab, Mr. Stephen Kipkerich. He's heading the National HIV Reference Laboratory, Kenya, at the Division of National Laboratory Services. He's in charge of the laboratory policy guidelines and strategic plans. He also coordinates sample referral systems and technical capacities for maintaining the quality needed for all that guarantees standards of testing at the National Reference Lab. Thank you. Let's appreciate Kerich. On our panel, we also have Mr. Gerald Masharia. He's a Vice President, East and Southern Africa Clinton Health Access Initiative. East and Southern Africa, under his jurisdiction, he has 13 countries, and he's previously been the country director for CHAI. He works closely with various governments to ensure that we have access to medical products and other health products. They also work with countries to design, fund, and execute public health programs that cut across various interventions across different diseases like HIV, lung disease, and others. Thank you. Let's appreciate Mr. Gerald. Lastly, on my panel, last but not least, we have Mr. Ronik Vora. He's the director, Revital Healthcare. I know in our opening statements, when UNAID was talking about the collaborations, they mentioned Revital, and he'll be talking to us more on local manufacturing, as he's a very accomplished industrialist and leader in medical device manufacturing. So, I think we go into the panel discussions, and at the end of the discussion, then we'll have a few questions. If you had a question for Dr. Nazila, who was our first presenter, who introduced this session, and she's really captured all the issues pertaining health products around local manufacturing, regulatory, digital transformation, KEMSA, and all the topics that the directorate handles. We have colleagues here who will be then chiming in those topics. So my first question will go to, I'll start with Dr. Gathecha. So we know that NCD drugs have not been heavily funded, but we've found a way as a program at NCD to ensure that patients can still access treatment for chronic conditions. What are some of the innovative solutions that have an enhanced access to these medications? And what are the lessons that other programs can learn from NCD? Thank you.
Thank you so much, Dr. Sarafina. So yes, you indeed put it rightly. NCD has been underfunded, but we've managed to bring access to the patient. And this is because we've been forced to be creative. We've been forced to be effective. That means more health for the dollar, and we've also been forced to be community-centered in our approach. One of the most powerful strategies is that we've moved our decentralized NCD care closer to the people in terms of the healthcare levels. And this has meant that we'd have to embrace task sharing. We've ensured that we've capacity built the clinical officers, nurses, to be able to initiate and monitor treatment at that lower level. And this has meant that it also has to be in tandem with the policies that are in place. And one of the greatest policies that have helped us achieve this is the Kenya Essential Medicines List. So one of our goals as a division is to ensure that with every subsequent revision, we're ensuring that the level of use of these medicines go lower and lower where it permits. And this has essentially meant that even in terms of affordability, if it's available at primary healthcare level, that means it's more accessible to the patient. And if I can give an example, the recent quality of care survey noted that the first-line medicines, for example, for diabetes, metformin, was available in 65% of the health centers, while HCTZ for hypertension was available at 63% of the health centers. So these figures might appear modest, but where we are coming from, it's actually a success stories that you can actually go to a health center and find all these drugs there. Another great achievement is because of the capabilities of the counties. Our food soldiers at the counties are NCD coordinators, and I noted a few of them in this conference. So we've worked with them to ensure that they are planning for the persons living with NCDs at par, so that at least there is the forecasting and quantification tool, which in turn helps to improve the KEMSA fill rates. Another, and because counties are varying their approach, I have one success story of Vihiga County, which in addition to use the data for making a case for improved or prioritization of NCDs, they're able to ensure that at ward level, there's 300,000 Kenyan shillings, which is earmarked for NCDs medicines for every quarter. This is because of advocacy and also because of demonstrating with their data that indeed NCDs is a problem and the county needs to look at it. We've also had help externally, and this is through leveraging public-private partnerships. When you look at the area of cancer medicines, they can be quite costly, but as a government, we've entered into agreements, MOUs with some of these pharmaceutical companies. And for example, we have a drug for treating breast cancer, Herceptin, which has been subsidized with a partnership with Roche. Glivec, which treats chronic myeloid leukemia. If it was not, it's offered at free actually for such patients, and it's available at public health facilities. If it was not if it was at a cost, it would be costing the patient for generics around 60,000 per month, which is quite out of the reach of patients. And then another thing, we've made access better by improving affordability. So this is where SHA comes in. There are 3 different funds for SHA. At private level now, the PHC fund, there is more drugs that are able to be reimbursed for NCDs. Then when SHIF, of course, there is that increased coverage for 5,000 per month, for 5,000 per quarter, for example, for diabetes, which also goes in hand with diagnostics. So for NCDs, it's also important for you to take the measurements, the various measurements on a quarterly basis, so that you can adjust medicines if required. So this has also been made affordable through the SHIF. And then also the issue of access to care for things like dialysis, which, truth be said, would be very out of reach for many Kenyans if it was not subsidized through insurance. And then lastly, earlier on, as a program, we learned that our path is not that heavy, and there's no point of reinventing the wheel. So we've made inroads into trying to leverage on other programs like HIV, maternal health, for example, for cancer screening. And if I can narrow it down to, for example, a person living with HIV and hypertension, for example, if you're going to have different clinic days, it's bothersome, it's cumbersome for the patient, but having the patient seen in the same setting means that you're saving them that additional transport cost, and you're also saving them the other indirect cost of healthcare associated with multiple visits. So integration, we learned, is the way to go from earlier on. And in conclusion, my advice to other patients, to other programs, is that it only works if you entrench or integrate or use anything within the existing health systems. Parallel systems are really not going to be sustainable at the future. And then riding on the health agenda of the day will also progress whatever it is that you need for that particular program to go forward. Thank you.
Thank you very much, Dr. Gathesha. Maybe there was a question of being able to get ARVs for free, but when they go to get NCDs, they are charged. But you've mentioned that there are initiatives of trying to have subsidized prices. Do we see a future of accessing NCD medications for free? Can we be able to get any initiatives that could support the patients who are living both with other chronic illnesses, non-communicable, and HIV to access these medications, either at subsidized rates or free?
Yes, the good thing is that it's already happening, maybe not at scale. And if I can talk about 3 initiatives. The first one is a bit temporarily. Recently, we got a donations from the UAE
Yes.
on some first-line medicines for hypertension and diabetes, and this will cover us for the next 3 years. And I think that's why Dr. Nalzila was talking about a donations policy. This will be available for patients free of charge at all types of Kenya. We've tried to distribute according to the burden. So at least for the next 3 years, we are covered with the first line treatment for diabetes, hypertension.
Wow.
And then for cancer, there's also direct money we get from the exchequer, from Treasury, for the purchase of 20 chemotherapy drugs, which we supply to the chemotherapy centers that are around 14 in the country for free. And then the county initiatives, and it was talked about earlier on, FIF. It's already doing wonders where facilities are able to repurpose that money directly to fill in the medicines where that are fast moving, to fill in medicines where they are needed in terms of their burden. So all this is happening. And lastly, India, for example, which is a much bigger population than Kenya, is offering first-line medicines for hypertension for free. I think it's not impossible. It's very possible in the near future, and we are there.
Thank you very much. Thank you. There's hope. To you, Dr. Immaculate. I know TB and HIV are conjoined at the hip, and TB seems to be doing well in integrating forecasting for their and procurement of the TB commodities. Will we say that TB program is now currently moving away from disease-specific, just focusing on the TB and handling the patient in terms of forecasting for your products? Or how is the TB program going towards integration?
Thank you, Dr. and good evening, everyone. I'll start by adding a rejoinder. The TB program is joined to the HIV program, but has tentacles. Yes. We are a TB, leprosy, and lung health program.
Yes.
So already by very nature we integrated, because then the services we offer go way beyond tuberculosis.
Yes.
Now, going back to your question about integration of forecasting and quantification, the process in itself, and it takes us back to what we mean by integration.
Yeah.
I believe integration does not mean all. I believe integration does not mean that all the disease managers in Kenya sit down in one room and quantify, because then they are not quantifying the same commodity. However, there is value in ensuring that the quantification and forecasting process is aligned when it comes to timelines and processes. Meaning that even though from where I sit, I may need rifampicin and the HIV program might need Lencap and the malaria program may need chloroquine or saoquinine, then it just means that at the time when the quantification lists are going out, all the programs are harmonized in the timing for which they do it. Secondly, there is the process of which systems are we using to collect our data and to undertake the forecasting and quantification. Now, for the program, what we've done is we've invested heavily in building capacity all the way from facility, county, sub-county, and to the national level in making sure that our data is integrated within the Kenya Health Information Management System, and also using the systems within the KEMSA agency to be able to undertake forecasting and quantification. Then the third thing is, apart from aligning the timelines and apart from aligning the systems that we're using, the resources that go towards procurement of TB commodities, we already have 70% of our first-line medicines being actually bought by the exchequer, meaning that when government budgeting processes are being done, then the needs for the TB program commodities are also included, and we are looking to scale that up across the years. Therefore, taking us towards integration being a process where there is harmonization in the way this quantifying of the needs for each program are done. And then the last thing is the distribution process. Now for TB commodities, what we see is that we have our commodities distributed together with other commodities from the KEMSA supply chain warehouses, meaning that when the family planning commodities, when the HIV treatment commodities, and all the other medicines are going out, then the TB commodities are part of that process, so that then we remove the need to verticalize or deploy our commodities in a parallel system.
Thank you very much, Dr. Just on the same issue of quantification, so you've mentioned that we need to align so that the data can come to, like when they're putting data into KHIS, we can do it for HIV, for TB. Could we say that the data that we use from the counties the data is reliable for decision making or for quantification from your end at the TB level?
I would say yes.
Yes, okay.
Not that we do not have our challenges, but at least we've ensured that all the providers at facility level are trained on the recording and reporting tools, and they also use the systems that are owned by the government to be able to report on that. However, certain challenges exist. First and foremost, you'll realize that the data that is entered into that system is only as good as the data in the store where these commodities are being mentioned. Now, so far we've seen digitization stopping at the pharmacy where dispensing is being done. But the management systems for stocks within facilities are not yet digitized. So we still have paper-based stock cards in the store where the commodities are done. So those are the ones that are summarized together with, in some cases where the facilities are not digitized, we have paper-based tools, recording and reporting tools for commodity consumption being aggregated to provide the data that is being entered into the system. So to the largest extent, yes, the data is good quality because the capacity has been developed. However, gaps exist so that in instances where there are gaps in availability of the hard copies of the tools, then we may have breaks within the system, and therefore we have to rely on making sure that these people go and collect that data using alternative tools, and some of the indicators might be missing. Secondly, when you're relying on a paper-based versus a digitized tool allows you to have real-time data for decision making. When we have paper-based tool, then we have to go through a process of verifying the data that has come in through the system, making sure that it's consistent, and then making sure that it informs the planning for the next season. Now, a lot of the data that we have is consumption-based data. Now, whereas facilities are digitized, there is no correlation between the commodity consumption data and the patient management data, meaning that there is no correlation between the morbidity, as it were, and the consumption of the commodities. Therefore, calling on a need to ensure that the data systems are harmonized so that right from the facility, from the source of the data, then it's very easy to confirm that indeed they used X number of commodities and it correlates with the number of patients that they actually saw. That way we have a harmonized and a seamless system that allows us to make sure that the consumption data and the morbidity data is matching. Now that will ensure that when we do our forecasting and quantification, we do not have gaps resulting from either under quantifying or expiries that are coming from overstocking. But so far, I would say for the TB program, we've managed to ensure that at least the commodity component of the data is working. And we have a team that sits and every month correlates that data now with our TB data, which is also electronic, to make sure that we are correlating the consumption and the patient morbidity data.
Thank you very much, Dr. Immaculate. Dr. Imbuki, the HIV program, HPT, falls under your docket, and we have a good history of the strongest commodity security systems with the HIV program. So what are the lessons that we learn from this system to then move into the broader integrated way of managing commodities, such that we are able then to have TB products, NCD products. Also, we build on a system where we can have visibility across these diseases while making commodity security visible.
Yeah, thank you. I think from the HIV program perspective, what has really helped us up to where we are is first of all, the planning aspect. Over the years, we've learned that you need to plan early. So for example, right now we've just done our forecasting and supply planning. We are just finalizing on that. And this is for the next 3 financial years. So it means we are looking at it planning early. So the other aspect, of course, it is around decentralization in 2 aspects. So one is you can access services, for example, the HIV testing in over 8,000 facilities. Out of those, we have around 3,800 that offer the ART. But the second and more important aspect is now decentralizing management of orders. And we've done this so well with the ART and the lab, where the sub-county teams, that is the sub-county pharmacists and the sub-county lab technologists are really the engine. And of course, over time, since they're really the officers at the ground, so to say, that has helped us in terms of improving our reporting rates and even reporting timelines, because you see, it is upon those officers to ensure there is actually security of health products in their sub-counties. So they are the ones who follow up on the reporting timelines and all these other aspects. And of course, building into that, you will now have that component of ownership, even the data we are talking about, since we have decentralized. There's a time we used to do everything at the national level, looking at reports and managing all those aspects, but now counties are now in charge. Thirdly, I think I'll talk about the issues around data and really data systems, because there's a time in this country we used to do manual reports. We send manual reports by G4S, but we, as a program, I think around 2018, we fully moved into KHIS reporting. And at some point, really, just to show resilience and even having sustainability components, with the support, I think for a long time we were using tools supported in this case by CHAI, but over time now, currently we are actually using the KEMSA LMI system, and that shows you that we've strengthened in-country systems just to ensure we remain resilient. And finally, so that because of time, of course, along that chain, there has been building of capacity, because if you are trained, for example, on management of HPTs related to HIV, it means whichever other HPT comes your way, it is the same principles. We've also invested, of course, with the support of the Pharmacy and Poisons Board around pharmacovigilance. If you check, for example, our pharmacovigilance reports, you'll always see it is the ART. Over 70% of the reports are actually around the ART. Thank you.
Maybe just quickly before you hand over the mic, Doc, we are talking integration, and this might mean if certain models are adopted, there'll be a lot of patient overflow into facilities, because some facilities might adopt maybe an outpatient model where all patients are being seen in the outpatient. So what are the innovative ways that the health products unit is looking at to decongest facilities, and also just to ensure that clients who are stable don't have to then come to the facilities and go on the long queues?
Okay, so thank you. Around, I think, September 2023, the ministry launched the private sector engagement framework, which is really a policy document for us on how to engage the private sector better. Of course, even among the 3,800 facilities, some are actually FBO, some are private, and some are NGO. But now as a program, we decided to adopt one of the community-based differentiated service delivery models, which is having ARVs dispensed through private pharmacies. And the program has picked up. We are currently working in 8 counties, that is all the cities with the exception of Uasin Gishu, which will be on board, but maybe I can just name them. Starting with the county where we are, that is Mombasa. We have Nairobi, we have Machakos, we also have Kiambu, Nakuru, Kisumu, and Kisii, plus Meru. We'll soon on board another 4 that include Nyeri, Kajiado, Uasin Gishu, and Kakamega County. So far, we have over 1,200 recipients of care that have enrolled into the model. And just to ensure the model is also self-sustaining, those who opt into the model because of the convenience and flexibility it offers, they are paying a nominal dispensing fee. So we are just on the scale-up phase. And of course, what we are also seeing with the launch of the new guidelines, where we will also be having the 6 months of dispensing, we will really have, for example, if you are in a facility, you are enrolled, and then you get the 6 months, you go to a private pharmacy, probably get your 3 months of your ARVs. It means clients will be taking 9 to 12 months just to go back to the facility. Yes, thank you.
Thank you very much, Daktari. That will help with stable patients who are then able to pick their commodities from the community pharmacies. So we could switch gears to diagnostics, and I'll begin with Stephen Kerich. Yeah. So how can countries build integrated laboratory systems? And is our system as a country in Kenya integrated?
Thank you, Chair, for that question. I think the system in the country is ready for integration. One of the components that we have currently within our framework, within our policy, and within our guideline, we do have all signs of integration. One is the integrated sample referral system. We used to refer samples vertically. Each program, HIV, TB, and other programs for surveillance, they used to refer their samples separately. But currently, we have one account. We have one system for shipping samples from the county level to the national level. Counties have gone ahead because there's an integrated national guidelines for sample referral. Counties have also domesticated, contextualized that, and developed the county-specific plans for referring samples within the counties from the primary health care level, lower levels, to sub-county and then to the county. So every county has costed that particular plan, and they do have it, and we are hoping that it's going to inform allocation of resources to be able to roll out that service. The second one was the integrated quality assurance schemes that we have at the national level. We have an ISO 17043 accredited scheme that actually rolling out accreditation and rolling out the panel testing to the laboratories in the country. And they have scopes like TB, they have HIV, they have malaria, they have microbiology, they have clinical chemistry samples. So these samples are actually characterized and shipped
to facilities to be able to monitor the level of quality of testing. And that is one of the areas that is very key, especially for the national institutions, to interrogate the issues of quality of testing in those facilities. At the primary health network level, at the lower levels, is where we are all interested to see how we will integrate HIV that was being tested at HTS. How can it take care of our comorbidities? And that is the conversation that we need to engage, including the communities. Where do you want your service? Do you want your service at the point of care, or sometimes would you like to delay, especially if the infrastructure is not supporting? If we refer a patient, those are catastrophic tests, costs that we might not actually, some of them will be lost to follow-up. So what we needed to do was to ensure that at the lowest level facility, if they don't have a lab and they have a point of care testing site, we ensure that we go agnostic, that is having several point of care for multi-disease testing at that point. And we deploy POCTs because it will be the game changer here. So we expect that at our dispensary and at our health center where we don't have labs, we should be able to have point of care testing hubs that are closer to the populations that we serve. And that will ensure that the uptake of services, because diagnostics sometimes is a gateway to entry point to care and treatment. So we expect that we build up the diagnostic facilities as we plan to build labs. The ideal is to have lab in every dispensary and health center. If that ideal is expensive, the option is to have point of care deployed near patient testing. The third one is either to strengthen the sample referral system so that we can move samples to the places where we have laboratories. And that has been informed by diagnostic network optimization that we've done in this country. The report is there. It tells you this gene expert is not optimized. It can still take EID. It can still take human papillomavirus testing. And that has been a game changer in the country as we move forward.
Thank you very much. With the mention of the POC machines, the point of care machines, can we say that as a country we have machines that can do multiple disease testing? And could we just mention a few and where they are located so that our members can know where to access these services?
Thank you, Chair. I think I will first start from the conventional platforms that are standardized, and the standardization has given us an advantage of a supply chain, predictable supply chain pipeline. And we've been supported through the office in NASCO that we do joint quantification and projection for our commodities. We do the supply chain pipeline, we look at our numbers, and we look at our throughput of the platforms. Currently, we have 15 laboratories that are testing viral loads, and the target is around 1.6 million tests per year. And basically, these labs are located, we have in Nyanza region, I think we have Migori, we have Kisumu, we have CDC, Kisian in Kemri, and then we have on the other side, we're also having Busia as a MOH facility, the latest entrance to the testing sites. But we have Kemri Alupe that is doing us good. And then we have Nairobi. So we have 15 of them. And geographically, their locations have been mapped to support certain counties. So there's a map for referral system to support counties. We have also POCT that have been valuable, especially in ASAL counties. They are expansive, and we needed to deploy POC platforms. We have Gene Expert, we have PIMA machines, we have AliaQ. So we have those instruments in those facilities. And the science was supported by diagnostic network optimization report, the deployment of those technologies. So we just don't deploy anyhowly, we deploy using the numbers, and the referral is telling us where are the redundancies, and then we upgrade some of the sites, some of the spokes into hubs. So we have the hub and spoke model that we are using in the DNO, and it is actually supporting us to be able to tell us it's easier to move a sample from here to the other one. Now the question is, the machines can support multi-disease testing. A county is willing to invest in it to be able to power their diagnostics. Then the second one is, how will be the payment system, especially when in County A, their nearest facility for referral is in the next county, but that is the nearest. How do we do cost reimbursement within the existing frameworks or within the SHA? So how do we do cost reimbursements? Those have been our discussions that counties will engage in, and we expect that we'll get solutions from a discussion like this, knowing that if a dispensary in SHA, you pay once. So if a patient is received here, the payment gateway is the dispensary. They pay for everything, including the test that they will not do here. Yes. Then they refer the patient because they will not pay in the next facility. So when the next facility does the tests, there has to be a mechanism of reimbursement for us to keep them afloat in terms of doing the tests. So it is engagement and it's a discussion that I hope the sample referral system will capture and will address it, because they have done the plans and plans are costed.
Yes. Thank you very much, Kerich. Those are very insightful considerations going into the planning on how the sample referral will not affect the SHA disbursements. So I hope that as you finalize on the framework, we'll be able to capture such. So at this point, I'll invite Dr. Wako to just then tell us how technologies are transforming the supply space. You're the national supply agency. You handle all the health products and also the non-pharmaceuticals. So how are you embracing technology to change our distribution of commodities, and how is it helping us better integration?
Thank you very much, Dr. Sarafina. This is a good opportunity, I think a very good conference. I think we need to look at our supply chain. All this actually boils down to commodities. Are they available to that mother that requires? Is the vaccine available at the right time, at the right place for the child? So supply chain is very key. Universal health coverage, reaching everyone, is very, very important. So for us now to have a system that will help us not to be reactive or to react to situations, we have embarked on developing a system that we are already using for the last 3 years, a global award-winning system called the Integrated Logistics Management Information System. Basically, it addresses 3 very big thematic areas. One of the very good areas that it addresses is what we call CWAS, the Commodity Early Warning System, where it tells you both overstocking and understocking in real time. So you are able to react, and in time look at where do we have the understocking or overstocking. Is it at the peripheral facilities or is it at the central warehouse, and correct that situation. So it is a real-time situation that you can respond to. Then the other one is what we call ARIMA. ARIMA is an autoregressive integrated system, where this is an AI system that it now plays with data, predictive analytics, and also looking at the patterns of use of commodities, the seasonalities, and then it gives you very good information on what are the forecasting and demand, what are the at the facility levels, for example, what are the demand that we expect, so that there are no surprises in the systems that we want to know. If for example, facilities start ordering, over-ordering, we are able to tell them, no, according to your patterns, this is what you really need to demand the quantities, and even at our own warehouses. Then the other one is The other big model is around the distribution and the last mile. It helps us, for example, we have the e-lock system. Once the trucks are e-locked, you are not able to touch that truck until it reaches the programmed facility. So if you touch that before, it will send signal back to the system that there is tampering. So this will help us in reducing leakages and pilferages along the way. Then there is the electronic proof of delivery. Once these goods reach the facilities, the system reports back that these goods have arrived. So the EPODs and the route optimization. So these three big modules really help us to look at things in real time, to use data, to use AI, to inform our supply chain systems. In good time, we avoid issues like reactive or surprises. So now, to the point where nowadays, we don't ask what went wrong. We ask what can we do to fix an anticipated issue. So again, the system is very upbeat in terms of now the relationship with our stakeholders. For example, facilities have stopped doing paper-based ordering, so they are using systems, the LMI system, to make orders in real time to us, and then we process their orders entirely through the systems. It helps in all these good things. You talk about accountability, traceability, auditability. So it has really improved the trust that development partners and our stakeholders have with KEMSA. Because if you're able to track your commodities very, very well, what are the stock levels, what are the orders that are pending, you are really, really attached to your customers, be they the facilities, be they the development partners that support us in family planning, HIV, malaria, TB. They have visibility of all these commodities, and this really helps us to build the trust and to avoid surprises, to live to the true, the 7 rights of a supply chain system, the right place, the right quantities, the right time, and all the rights. So this is the system that we have deployed. It has won like almost 5 global awards, global health supply chain conferences, big conferences. KEMSA has been able to scoop these awards. The other beauty about this is that it's not a partner-led system. It is KEMSA's own system developed by KEMSA. Partners found us there and they have supported. We must acknowledge their support, but it is a homegrown solution to avoid darkness in supply chain, to be visible, to be seen. We have had countries that come to benchmark with us. We've been able to support some of the countries to develop their own systems. So that is KEMSA for you. We can proudly say now that we are really transparent, we are accountable, our commodities are quite traceable and auditable. So that is the system that we have deployed for you. And yeah, let me stop there, and if there are any other questions, we can.
Thank you, Daktari. The National Supply Chain Agency has really adopted to the technologies, and we've seen changes in the system, and even the end users can attest. However, there are issues around the fill rates. Facilities will want to order for drugs, but as they do, they get 70% fill rate, they get lower fill rates. What will you say around the things that you're putting in place to ensure that we move towards 100% fill rates?
Thank you, Dr. In terms of the order fill rates, for program commodities, we have no issues for the HIV, malaria, TB, family planning. We have that nice relationship that Dr. Mboki and Immaculate have really described, where partners come together and identify in good time what will be the input of Global Fund, PEPFAR, or the government, and others, and then really look at the demand for some time and fill up the spaces. So for those who may not have issues around order fill rates, what we are grappling with is the essential medicines, the essential ones which are very critical to address the common ailments that bedevil our people. I must proudly say we've come in the last 1 year, 1.5 years, we've come from a 48% to now over 90% order fill rate without much interventions or looking at the largest amounts of monies you can receive. No, we just had to, I know we don't have a lot of time, we just had to relook at our business model. What do we do that needs to be changed here and there? I can just give you 2, 3 examples. One of the examples is people are struggling with old policies that you must have 6 months stock of every commodity. We said, let's get something I called shrink and expand. Why do you have to keep things, very thinly for 6 months? You are not able to catch up with that, with the limited resources that we have. Why don't we get essential commodities for at least 3 months, then circulate these 4 times a year? So that really boosted us a lot. Then we looked at our list. KEMSA was trying to buy 3,800 lines of commodities. We said, do we need all this? What do facilities and counties ask for commonly? I formed a task force, and they came up with 485 that are commonly asked for. Then we said, let's buy these ones. This is what describes our order fill rate, not the 3,800. Fine, you can buy some of those, but let's have this for at least 3 months and churn like 4 times. And that really magically moved our order fill rate very, very fast. So those are some of the things that we did. And of course, administratively, unless you keep a tab on things usually disappear. If you discuss like in this conference and let it go, things will not work. So I formed a team called the SCORE team. SCORE is a supply chain optimization team that meets every week and considers every tablet or every line what we call SKUs, stock keeping units, SKUs, line by line, and say this Panadol has a life, and you have to monitor this Panadol itself, the amoxicillin by itself, everything by itself, no generalizations, and got focused on that. And I tell you, this has done magic. But you can come down to Embakasi for more details.
Thank you, Daktari. We are grateful. So we'll go to the last part of health products, and that is manufacturing. Local manufacturing, as Dr. Nazila had mentioned, is one of the key pillars. And for that, I have Mr. Macharia and Mr. Ronik. So Mr. Macharia, maybe just a quick one. CHAI has been very instrumental in ensuring access to newer products in different countries. And you've used different mechanisms like price negotiations, you've supported local manufacturing. So from your end, what will be the challenges that how you've observed in these countries that have gone the local manufacturing way?
Thank you. Thank you, Sarafina. We actually just published our market shaping, guidebook, and it will come on our website. 150 deals worth billions of dollars over the last 20 years. And we just put all the information together and actually made a handbook out of our market shaping work. So you'll find a lot of information in that handbook when we publish it on our website. But largely, there's a whole science behind the way we shape markets, which I won't go into right now. But aggregating demand is a starting point that then ends up inside the production plant and optimizes the production process.
and generates savings out of that production process. And it's everything from taking the mechanism apart and doing ABC costing and activity-based costing, that's what it's for, ABC costing, and then repackaging the cost structure to build in enough of a margin and a return to investors. So it's not just negotiating a price, it is actually work that we do with each manufacturer to make sure that they stay in business, even when we arrive at an optimal price point. But that involves demand side work, which is aggregating demand and figuring out the pathways to that demand, but also coming back and gutting production lines to make sure that even as we are asking for a price point that is good both ways, we're not asking you to lose money as a manufacturer. And so you find a lot of issues, in most countries where the volumes are not good enough, and governments are probably not willing to commit money long term, and so you have to navigate, all those things and come to a point where you can say this is the optimal demand level across 17, 18, 19, 20 countries. And we can syndicate that demand across X number of manufacturers who are willing to come to the table and work with us, on that point. But again, what are the issues that we find when we sit down with manufacturers? It's three things. It is access to capital, it is technology, and it's market access. Those are the three things that are very thorny issues for manufacturers. Capital is available if you read the headlines. It is not available when you talk to the manufacturers. So there's capital available. Every day there is somebody, a DFI, development finance institution, private equity fund saying, well, I have X amount of money available for African manufacturers, until you get to the manufacturer's premises and you find that the access is just there on the headline. So there's a lot of work that is involved in there. Technology transfer, same thing. If you go to the medicines patent pool, and Robert is here from Unitate, they fund MPP. There are licenses sitting there that no African manufacturer has ever had access to. So where are the pathways, to the technology transfer that would then make it possible to have a lower priced, optimally priced product, HPT, in the market? And of course, market access issue, is WACO here willing to give a 5-year framework contract to Universal Corporation, to supply analgesics? You find several policy issues there that will prevent him from doing that, and yet that is what your manufacturer is ideally looking for, in order then to walk backwards, spend money on technology transfer, and access capital that makes sense to them. So those are the three things that we grapple with all the time, even with our 20 years of shaping markets. Yeah.
Thank you, Mr. Machare. I know with the experience of chai and those three have still stuck, then we need to align our policies so that we can support local manufacturing. So what role does the partners play, apart from chai? What will you encourage partners to play to then promote local manufacturing?
So I think first it begins actually with the market itself, which is largely government. And the policy environment, which is an enabler, the complaints that always come around the policy environment, taxes, the tax regime, input costs, value added, all those things. If you ask Nazila here for a list of complaints, that is like half the list is about the tax regime, So we need to put the noise down, and I'm sure Ranik will tell you about his experience in that policy environment. So we need to fix that, but also to make the markets make sense. We need to be able to allow KEMSA to come back and report on the items that are there on the list of preferred procurement for local manufacturers, And actually tell the country and all the policymakers how much of these 140 items that I need to buy locally have I actually bought this year? So that report never comes through. And those are the sort of things that would encourage a reluctant manufacturer to put investment down to be able to address that kind of market if there is assurance there. So partners will come in and provide whatever support you can. Volume guarantees, for instance, where we can come in and say, if WACO commits to X number of volumes over the next 5 years, we will actually provide you with a volume guarantee to make sure that whatever he doesn't buy, then we'll pay you, for the cost of producing what he doesn't buy. That's how volume guarantees work. And those are mechanisms we use all the time to make markets work. So there are things that we can do. There is advisory services that we can provide to manufacturers. There are a lot of market things that we can do. In chai, we do reverse chemistry, on some molecules. We have a lab somewhere in the US where if it's necessary for us to do reverse chemistry, then we'll do reverse chemistry to make a product much cheaper than would be the case in the first place. So there are a number of things that are then there are various entities. MPP is one of them. MMV, which is a malaria medicines venture. There are quite a number of entities involved. D&DI, drug discovery, the market access issues, demand aggregation. There's a lot of work that partners can do, but ultimately, government is still the biggest market. Policy environment has to work for all those initiatives to make sense.
Thank you very much, Mr. Macharia. I think if you're given the platform, you'll school us on the intricacies behind the local manufacturing. Thank you. So at this point, you'll allow me to bring Mr. Ronik in. He's one of the local manufacturers, and United are partnering with him. So maybe, Ronik, you could just tell us the significant strides that you've made in local manufacturing, and any of the practical lessons you'll want to share with us on what has worked for local manufacturing and what are the bottlenecks. So we can start with what has worked that has enabled local manufacturing for you.
So Revital Healthcare, it's a very small factory, just less than 10 kilometers this way, manufacturing about 58 medical devices, diagnostics, and as well as laboratory consumables, and exporting now to about 48 countries around the world. So not only in Africa, but even Asia, Europe, South America, and for the first time in the history of Kenya and Africa as a continent, we sent products to Australia just about 10 days ago. So it's a big accomplishment on what we're trying to do. And what's the practical thing is, when you set up an industry like this, you have to have two things in mind. First of all, is it commercially viable? Does it make sense to spend 600 million shillings to set up the largest rapid diagnostic test kits facility in Africa, which is end-to-end manufacturing to produce HIV test kits, malaria test kits, hepatitis? These are all communicable disease that's killing millions of us in Africa year on year. So first and foremost, does it make practical sense? Second of all, is there support that's provided? We have donor funding organizations like United, Gates Foundation, and so on and so forth, who has supported Revital previously. In fact, with the grant that we received in 2021 from the Gates Foundation for $4 million, we innovated the world's first early activation syringe, which till to date, we have supplied over 600 million pieces across the globe. I mean, I'm talking about countries like Ukraine, Bangladesh, Pakistan, Sri Lanka, Nepal, all from Kilifi. We wouldn't be able to understand that Kenya as a country, Africa as a continent, has a capacity to produce high quality medical devices. And one of the main reasons why as well is because we invest a lot in our certification. We spend about close to 200 million shillings a year in just certifications, WHO PQS, ISO, CE, US FDA, MDSAP, and then we have in-country registrations. Africa needs to learn from Europe, where 54 countries in Africa, if you have 55 products, you go to every single country, you pay a registration fee, and then you access that market. Look at Europe, for example. They have one certification, CE. If you're CE certified, you export to any country in Europe. Why can't Africa have a policy like this? This way, local manufacturers like me, and I see manufacturers in the room as well, will have the capacity to continuously invest in the production capacities. When we started this factory, we were producing 60 million pieces, and we are employing 60 people only in Revital. In a span of 17 years, with the certifications that we're able to get on board, the markets that we're able to access, not only Kenya, but globally as well, we now produce 2.2 billion medical devices per year and exporting to all those countries around the world. So it has to make commercial sense. There has to be a political agenda to support local manufacturers. For example, Uganda, just next door to us, they support local manufacturers. You set up a gloves factory, NMS, which is a National Medical Stores Department in Uganda, will come to your doors with an offtake agreement. You have set up this factory, we will buy you 100% of your capacity. That's what we need to see in Kenya. That's how industries like Revital will come up. We just don't want one Revital. We want multiple Revitals coming up, and we want Revitals to manufacture all the products there are in the commodity space. Dr. Wako mentioned 3,800 products. If you ask Dr. Wako, out of those 3,800 products, what is locally manufactured and what is imported, you'll see a glaring fact. 75% of whatever Africa buys year on year is coming from outside of Africa. And that goes to show the glaring scarcity that we have in the continent. COVID was a very important reminder to all of us. We didn't have something like face masks. We didn't have PPE kits. We were importing these products from outside of Africa. And eventually, we started creating capacities like this. We're not far from COVID. We're seeing what's happening with the war right now. We are going to face the same situation. There will be scarcities. Raw material prices have shot up. Freight containers are going to seize. We're going to see these catastrophic events happening very soon again. And as a country, we need to make sure that we're prepared. And as a continent, we also need to make sure we are prepared.
Thank you very much, Ronik. I wish we had more time, but I see the room is almost getting empty, so we will want to stop here and maybe just allow a question. Oh. Wow, okay. Wow. So we are adults. We are the cost. It's 1756. So how many questions could we take? Maybe I could, okay. Let me use the microphone. Although maybe the questions will be yours. Okay. So we'll just take two questions. From this side, a lady. From this side, a gent. It's also a lady. Oh, there's a gent on the other end. So, a gent, comments. So, Dr. Newton. Okay. Two questions. So we have a lady on that end. Please go ahead and ask your question.
Thank you. My name is Susan Meta, HD champion, Kisumu West. I have two questions very fast. The first question is in regards to KEMSA. We have frequent stockouts. As we are getting fully integrated, when it comes to advanced HIV disease patients, we are having a problem. For us to identify an AHD patient, they must be tested through CD4. We do not have CD4s. And we've not been having, actually since December, we had to borrow somewhere. We only got like 15 of them. And that is a challenge for us because there is no way we can be able to identify an AHD client without the CD4. That is how we can do the S-CRAG. Sometimes we don't even have the serum CRAG. Sometimes we don't have the gene expert. So for rural facilities, how can you help us as we are getting fully integrated for the HD patients? How can you help us to make sure that we have those commodities? And then the last one, when it comes to the CPM model, I think for me, I would fully support it. In our facility, we have like a 5,300 TX car. That means we have a lot of patients the first 3 weeks of the month. Now for us, the challenge would be because we are dealing with the aging. Is there a way you can come together with the pharmacies and come up with a package in SHA whereby instead of paying the 200 standard fee, the SHA can pay for that, because in our facility we have people who cannot even afford to pay for the 50 shilling consultation. So they would rather queue at the pharmacy because they cannot afford to go to other pharmacies and pick their drugs. Kindly, thank you.
Thank you very much.
Thank-
Nelson.
No, let
Okay,
me.
go ahead. I had not.
No, I've dropped all my questions. I have a comment.
No worries.
For the panelists and for yourself.
Thank
We are
you.
here, we can always discuss, and I know all these teams, we can reach out and then discuss.
Okay.
But I think the comment I have is, everything you do, including local manufacturing, you can actually do it much faster and better if you partnered with communities and civil society, because there's a way in which we can work to identify barriers together and then mount an advocacy on laws, policies, and regulations that hinder quick access. And this actually, under the presentation from Dr. Nazela, have been the integration we are looking for. Because remember, even yesterday, somebody was asking, how come we in HIV are being forced to integrate? The TB community are not, TB is not integrating. The head of TB program is here, and he told us, this is a Ministry of Health, this is a health thing. Yeah. So if we can always bring the voices of communities and educate them on what we mean, because probably we are talking about integration and it's not a very new thing. It is just the way we arrange our business that would be useful. Dr. Sarafina, you appear stressed. The questions were not meant to you. Allow Kamau to say one thing.
No, I'm seeing so many hands up, and it's already 6.
Yes, Dr. Sarafina.
Yes, Kamau.
How are you? 2 questions. Local manufacturing. What barriers in terms of taxes and everything else imported do you get that come in? Taxes of the raw materials and everything else that he does that make the product expensive.
Okay.
KEMSA, you're doing a good job, but how much does GOK and counties owe you? I mean, let this come out. We are civil society, and when we are doing the budget, we would be able to push it. Okay?
Thank you, Kamau.
And Dr.
Thank you very much. We'll take one more question from this end. There was a comment here. Helen has a mic in her hand, so you can go, Helen. Just a comment, please.
Thank you so much, Dr. Sarafina and the panelists. I just want to ride on what Dr. Kadure said. Thank you, Doc, because we have the systems in the county about integration. And in fact, for the diagnostic wing, we have integrated. But our issue is the national, the policy makers. For example, we have integrated the Gene Expert platforms to support us in multi-disease testing. But all the service maintenance is left for Dr. Kadure to undertake. But other members are taking it easy and pretty. So in this integration summit, we really need to come out as a team and actually share the costs, so that when you are talking about multi-disease testing platforms, we really share the cost across the cancer, the HIV, the TB, and all those that will be using these platforms. We also have integrated sample networking system, just like Kip said. But there's a problem somewhere with the SHA, which I think the national can also sort us out in terms of integration. If I have this patient at level 2, and I'm taking their samples to level 5, where should they pay? Is it at the level 2? And if they are paying at the level 2, will the SHA understand that the cost of a hemogram in level 2 might be different with the cost of a hemogram in level 5, including the biochemical tests that are supporting us actually to monitor the drug use among these kids? So when we are talking about integration, my last comment is, it is the national team to sort us out at the counties. We are ready, and we have started it small,
but we require a clear policy that will speak about the service maintenance of our equipment, the supply chain on how these commodities are going to come to us, and finally, the reimbursement processes that are going to be with us. Thank you.
Thank you very much, Helen. There's a hand there, and that's the last one. Then we'll allow Dr. Imbuki. You'll answer the first question. She had referred it to KEMSA, but I'll return it to you. And then there's a question for KEMSA. Kamau will want to go and advocate for the payment of the debts that the county owes you. Yeah, so it would be nice to answer that. For Dr. Kathore, it was a comment, and they are really fighting that we cost share. Yeah, so yes.
Thank you very much, Chair. My question is to Mr. Macharia. My name is Misiani. I'm the county pharmacist Kakamega. And I'm seeing us, we're experiencing what we might call a normalcy bias, where we think things are going to be the same, and yet probably the ground is changing right beneath our very feet. So I'd want to pick your mind to the extent that the changing fiscal space. We've seen USAID, we've seen Trump, we've seen global funds saying, guys, you need to more or less wake up because the funds are dwindling. Probably you could advise us as a country, as you're speaking about integration. The source of funding is going down. We seem to be hell-bent in thinking that things are still going to be okay, somewhat. So maybe you can give us that wake-up call so that we don't sleepwalk into a disaster when we saw it coming. Thank you.
Dr. Sarafina, Dr. Sarafina, there's a request to balance gender. We've had 3 men speak. Can we have one more lady, then we close?
Okay. Go ahead, she's my friend from Homa Bay at Anipiga.
Okay, thank you so much, Dr. Sarafina. I'm Emel Dodie from Homa Bay County. Mine is just on the facilities are buying drugs from the SHA fund, and you're getting drugs from KEMSA. How do KEMSA account for the drugs that are bought by the health facilities? Because if we go to the health facilities for supervision, we get most of the drugs are expired from KEMSA, and the facilities are telling us that they were brought when they were at short expiry. So I don't know, they use the ones they bought first and leave the ones that you supply late. So I don't know how we are accounting for them. Thank you so much.
Okay. So if I got you right, you concerned about the commodities or drugs that are bought using the SHA fund and the ones that they are supplied for free through KEMSA. So it seems like facilities want to use the ones they bought first, and some of them are even maybe longer expiries, leaving the ones that are free to expire. Okay. So I don't know if that will go to Imbuki or still Dr. Wako. So there's a question that has come from the other end from Dr. Misiani that he had directed to you, Mr. Macharia, but Ronik also wants to give his input. So we'll do this, we'll go with Dr. Imbuki, Dr. Wako, Ronik, and then Macharia. 1 minute each, please.
Yeah, so thank you. I think on the question on CD4, because to the best of my knowledge, we have products for the new technology, Visitect. So I'm saying my colleague there, Judy, I think you can link up with her so that we see how we can handle. But thank you for your comment on the community pharmacy model. Luckily, pharmacies have now been categorized as level 2 facilities. And I'm also seeing Dr. Newton, who is in the discussions around the benefits package for SHA. So I think he will pick that up. We've been having those discussions because it will be a good thing going forward that if that is under SHA, it will even now attract more recipients of care to the model. Thank you.
Thank you very much. I think I had two questions in a minute. Mr. Kamau, thank you for volunteering. Yes, when you're in a commercial business, you tend to have a lot of debts. What you sell and what you collect back does not mirror. So really, this makes sustaining that kind of order fill rate very, very difficult. We are in a very difficult situation. I will not shy away from saying that the counties owe us almost 3.5 billion. The single facilities owe us something like 700 to 800 million. So within counties, sometimes we trade directly with some of high volume facilities. So when you add this, about 700, 800 million is out there, 3.5 billion with counties. And some of these debts are quite long standing. So we can help so that we are proud of our systems. We deliver, we get paid on time, we pay the suppliers, and then we live happily ever after. Now, my sister there, sorry I didn't get your name, about expiries at the facilities. For KEMSA, the policy is very, very clear. It's extremely clear that we do not, by any means, deliver any commodity that has less than 6 months of life. That is by policy. It is a law. I'll be breaking the law to do that. So to not to do that, not to stick to that policy. KEMSA itself cannot accept goods that are 75%, less than 75% of shelf life. It's a policy, even from suppliers. We cannot receive. But there are exceptional cases when, you remember 75% is a lot of months, but for counties there is no change. For facilities, there is no change to the 6 months rule, only in a situation where if you have a medical camp, you ask us for what we call short-dated commodities. So we have commodities that have 6 months or less, then we convert these ones to CSR, corporate social responsibility, believing that the medical camp will utilize all that. But routine distribution, 6 months and above. We have a problem. Counties, freedom, democracy. Now, there's no law barring them from buying from other institutions or chemists across the fence. So these ones do not follow this policy. Sometimes they end up buying from across the fence or across other agencies that do not have this policy of 6 months, and then when they expire, they will not know the difference. They say these ones from chemists are expired. Ours never expire, by the way. And remember, the ILMS gives us a view of where the stocks are, the Integrated Logistics Management Information System. Did I have another question? No?
No, I think you've handled those ones, and thank you for
Thank you.
sticking to time. So we'll have Ronick, and then...
Thank you. I would like to answer your question. You're so right. US government has stopped funding because of Donald Trump. USAID has been disbanded. There are a lot of programs like HIV and others which are supported by these organizations in Kenya and across the continent of Africa. But now that the funding is stopped, we're starting to see a big problem, and that's witnessed in counties underneath. The problem is, why, as Revital is, the rapid test kits factory that we have, yes, it's a state-of-the-art factory. We have a capacity of 20 million test kits per month, but we're not WHO PQS approved. Kwani WHO PQS ni nani? Na funds ni yetu. Why is it that we're following guidelines issued by global funds and other procurement agencies across the world that ati wakiweka hiyo WHO PQS ndio unaanza kufaulu kubidi hiyo tender? Do you know this? A very interesting fact. What these guys do, they put these specific clauses so they can support their own companies in their own country. These rapid test kits are coming from where? Where do you think they're coming from? They're not coming from Africa. They're coming from there. The guys who are giving us the money. But now that the funding has stopped, we need to think like countries like Zimbabwe. Zimbabwe is the first country that I know in Africa who has refused funding from the US government for the HIV program because they want to fund their own monies for their own people. So Revital very soon will be setting up a factory in Zimbabwe to locally manufacture rapid test kits which will be bought by the government of Zimbabwe. We have PPB in Kenya, Pharmacy and Poisons Board. It's the national regulatory body in Kenya. If I'm approved by PPB, what's the problem? Do we not trust PPB as an entity or KEBS as an entity to do the testing, batch validations, giving us approvals, and then be able to sell to the government and the people of county and the private market? Do we not trust them as a regulatory body that they cannot equip local manufacturers? We're buying HIV test kits for up to $1, $2. I'm selling this test kit for 40 shillings. Malaria test kit, I'm selling it for 20 bob. Juicy fruit, the gum that we chew, is 10 bob. And I'm selling a malaria rapid test kit for 20 bob. So you can see that we have local capacities. The prices are very good, just that we don't have WHO PQS. Thank you.
So just adding on to, Ronique put it very well. So philosophically, money came in and we spent it because we had to spend it. We never asked how we were spending it. Now the money is gone, and it's gone for good. So this is the time we start asking, what were we actually paying for with that money? And did we need to actually pay for it? And if we didn't, then we come back and say, all those things that we were paying for because we needed to spend the money, remove them, so that we're genuinely paying for the things we actually needed, which means our own money will be able to do what we would have been able to do in the first place. So that should be the position, philosophically, that we should be looking at. If you ask me, if you put 25 billion here in front of Dr. Wako, we will take care of everybody who is HIV positive in this country, including diagnostics, with 25 billion Kenya shillings. 17 billion going to State House, add another 8, and we're good to go as a country. No, seriously, we're good to go. And that is the reality that we need to come home to, that we were paying for things that we did not need to pay for because the money was there. Now we need to ask the question, should we continue paying for the same things with no money? We shouldn't. It's a stupid question. You get a stupid answer if you ask that question. Thank you.
Thank you very much. At this juncture, please allow me to give the speakers who didn't have questions just to say a parting shot. Kipkerich, anything that you want to say as a parting shot?
I think as a parting shot, that when we start engaging in integration, it is good to think about the communities that are represented to be part of the discussion. And I'll be asking the communities, where do you want your tests to be done? Is it at the primary level or is it at the tertiary level? So that is the discussion, and we will engage further because we will not finish that discussion, and we will farm on, given the money that is not there. The labs are not forthcoming, so we need to do something.
Thank you. Dr. Immaculate?
Thank you, Daktari. Mine is two things. One, integration begins with the patient. The patient sits at the facility. We have a unified health workforce that is already looking at the patients that walk through their doors. It is upon us now as programs, as government, to make sure that we harmonize the systems and the structures that are required to make integration happen. So if it's reporting, let's not have an EMR that is peculiar to a disease, but an electronic health records that runs across the entire facility, so that then we remove that extra burden from the healthcare worker and make sure that the systems and structures that are required to see integration come to life are there. The second thing, integration will work only if we have harmonization in the cycles for funding and fund availability. You'll find that a lot of times, some of the disruptions in the harmonization of the procurement cycles is because the funds are available at different points within the financial year, or even the financial years are different. So probably time that we came together and said, for procurement for Kenya, this is when the procurement process starts. This is the window for procurement, and anybody that has resources from whatever sources needs to put their resources in during that particular window. It will remove a lot of hassles and headaches for my colleague, Dr. Wako, and make integration real. Thank you.
Thank you, Doc. Dr. Gatisha?
Yeah, thank you. So the greatest cost drivers for the healthcare systems and also for the person living with living with NCDs is the HPTs. So the best approach would actually to prevent the NCDs in the first place. And that's where the integration needs to start in the form of the messaging we are giving out there. It should also incorporate things or information that also reduces NCDs. But the next thing also, because NCDs will still occur because of the genetic nature, will be to ensure that the patients can access these medicines. So what do? It will be a myriad of interventions possible, and it also requires, again, the concerted efforts of everyone. Thank you.
Thank you very much. Thank you, audience, for keeping it until now. We appreciate you. I'll request that we step forward for a photo. Yeah. We can appreciate the team. Dr. Kapanga, come up.
Oh, just 1 minute, we close the day. 1 minute, we close the day officially. Thank you for staying over. And on behalf of, and one more clap for the panel that finished. I know you want to leave, so I just want to thank you for staying over up to 6:22 p.m. and have a good evening. Bye. I mean, guys are leaving, so I just want to end.